Okay, and we'll now start the second part of the morning, so we'll move into the 12th of October's meeting. Apologies, it's just getting the technology sorted out. In which case, we'll move on to the 12th of October's meeting. So we'll start with agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've had apologies for absence from Councillor Lucille Hayes, Councillor Mark Whittington and Liz Ball. We have replacement members today. Councillor Whittington. Yeah, Councillor Whittington. We have replacement members today. We have, and Councillor Cleaver, by the way, we've had apologies. We've got Councillor Overton in for Councillor Cleaver. We have Councillor Cathy Rice-Oxley for Mark Whittington, and we have Dean O'Dell for Liz Ball. We haven't got Councillor Boston yet, though, have we, Chairman? No. He's due to replace Councillor Haigh. Thank you, Chairman.
Okay, thank you. And welcome to Councillor Rice-Oxley, Councillor Overton and Dean. Thank you. We'll move on to agenda item 2, declarations of members' interests. Are there any to declare at this point? No, thank you. In which case, we'll move on to agenda item 3, the Chairman's announcements. My announcements have been circulated with the agenda on pages 3 to 7, and the supplementary announcements were circulated on the 11th of October. Are there any questions on this? No. In which case, do I have a proposal that we note these, please? Thank you, Councillor Linda Wootton. Seconder. Thank you, Councillor Allen. And all those in favour, please show. That's supported unanimously. Thank you. In which case, we'll now move on to agenda item 4, the East Midlands Ambulance NHS Trust. This item was circulated as part of the agenda packs on pages 9 to 22, and I would like to welcome our presenters via Teams, Sue Cousland, Divisional Director, Neil Scott, Service Development Manager, and this will be a PowerPoint presentation as well. So welcome to this morning's meeting. I'll give you about 15 minutes to run through and we'll take questions at the end. Before I'd hand over to you, just a reminder that I ask that all questions be succinct and concise and ideally no more than 2. Thank you.
Thank you, Councillor Macy. Good morning, everybody. My name is Sue Cousland. I'm Divisional Director for the Lincolnshire Division of East Midlands Ambulance Service, which does cover from Grimsby and Scunthorpe all the way through to the south of the county, Stamford and Market Deeping. So quite a large patch, as I think you'll remember from previous presentations. I have with me 2 colleagues today. When I've been previously, I've spoken about a restructure that we've had in our operational team across the trust. And I'm delighted to say that the 2 main senior members of the team are here today, and they're just going to introduce themselves, and they're responsible ostensibly for the bulk of work that happens in Greater Lincolnshire. So I'll hand over to Maria first.
Thank you. Good morning, I'm Maria Stanley. I'm the Head of Operations for the South Lincolnshire area. The stations within my area are Grantham and Stamford, Sleaford, Bourne, Holbeach and Spalding. I'm also have connections into Peterborough Hospital and the NWAFT system, and I'm currently building relationships with NWAFT, but also East of England as well.
Neil.
Here, I'm Neil Scott. I'm Head of Operations for the mid part of Lincolnshire. My main area of focus is with a relationship with ULHT as the Acute Provider Trust, as well as Lincolnshire Community Health Services from a community point of view. And I cover the patch that effectively is Lincoln, Mablethorpe, Skegness, Boston, Horncastle, the former East and West CCG areas, for those familiar with that boundary setup. Thank you.
Thank you both. Councillor Macy, there were 5 queries that came up as part of the information that we sent to you. The first one was category 5. We've now included, excuse me, a definition of that in the paper pack. There were a couple of queries around performance that Neil is going to pick up as we walk through the presentation. And in terms of leavers and joiners, the query there I will pick up, and also in mention of our colleagues from the voluntary sector who've been a great support to us as well. And we've included a slightly larger section, and I'm happy to expand on that verbally. So if there are no initial questions, we'll press on with the presentation. So first slide, please. Thank you. That was really just to remind people of the regional EMAS focus, strategy, safety, performance, resourcing, and leading to service improvement. So second slide, please. We've included this, that these are the national priorities for winter through NHS England. And as you can see, there is quite a lot of reference to ambulance trusts and the performance of ambulance within there. Certainly point 3, that increased resilience in 111 and 999 services. EMAS did increase their number of call handlers this time last year ahead of colleagues, interestingly, which means that we are in a very resilient position for call taking potential now. Sorry, could you just go back to the previous slide? That's it, thank you. Just to let you know that there is a system behind the scenes for call taking across all 11 ambulance trusts in the country, and there is an automatic feed where there are significant delays in 999 calls being handled, and it's fed through to different ambulance services by way of mutual aid. And I'm pleased to say that East Midlands Ambulance Service is consistently in the top 2 performers for answering 999 calls. But we are not resting on our laurels. We are recruiting a further number of call handlers, and they're being trained at the moment to help us cope with what we think is going to be a fairly challenging winter. The category 2 response times and ambulance handover delays, and Neil's going to deal with that in a little bit more detail. And we do work very closely with our system partners around A&E departments, front-end working, and also do try to help where we possibly can with the discharge home, because that means we keep the flow going. And as you've just alluded to, we will be taking over the patient transport service provision in Lincolnshire from June, July next year as well. So that will add greater resilience, we feel, to the offer in the county. So next slide, please. Those are our own winter priorities. Safe and effective care delivery. I think you'll see from performance, we are really struggling with our performance. We're doing an awful lot to ensure that we get the most time critical patients as quickly as we can. But we are very focused on safe and effective care delivery, and are happy to answer questions and queries in relation to that as we go through. We're also extremely focused on staff welfare, because you will see at the end our sickness levels and our retention is a cause for concern. But again, we're happy to talk through some of the work that we're doing in relation to that. So I'm going to hand over to Neil for the next few slides to talk us through our current performance. Neil, thank you.
Thank you, Sue. We can move to the next slide, please. Thank you. So what this data shows in the PowerPoint that's been circulated, it isn't the Lincolnshire position. This is the national position of where all the ambulance services sit in terms of, for this slide, category 1 performance. It's overlaid with the various periods of COVID. But as you can see from there, since we've come out of the phase 2 of COVID, if you like, there's been an almost exponential rise in Cat 1 performance, or deterioration in Cat 1 performance. Now, that is being felt by all of us, certainly, felt by us as the providers, and very much being felt by the patients. Lincolnshire is no different. The trend lines that you see here are virtual exact copies of the trend lines that you see for East Midlands as a region and for Lincolnshire as a division within that. The big difference that we have in performance in Lincolnshire, however, is that staggering effect, in that it's no secret that performance has always been a struggle to maintain in the rural areas of Lincolnshire, Cornwall, etc., parts of the country with geographical challenge and population spread. However, the trend line that we've seen in Lincolnshire is identical to this. So we're not an outlier in terms of what we're seeing. What we do see, unfortunately, is a magnified effect of what that means in terms of patient weight. Next slide, please. Thank you. So this is very much similar slide, and you'll see the trend line looks very similar. This is for category 2 response times, which makes up the bulk of the volume of our acutely unwell activity. We have category 1 through to 5, from highest life-threatening to lowest life-threatening, and category 2 really makes up that main bulk of the work we do. So any ripples in the pond in terms of activity, it's going to be seen and it's going to be felt in that category 2 place more than anything, because of just the volume of activity that's seen. Next slide, please. So EMAS performance, January-August 2022, what we've seen is a rise in calls. We've seen an increase in calls, and that's been seen nationally. That's not unique to Lincolnshire. And what we have seen is a significant increase in hear and treat. Hear and treat being the way that we dispose of a call. So if we receive a 999 call from the public or from another agency, and we deal with that with a clinician, be that a nurse or a paramedic or a mental health nurse over the phone, and close the call through signposting or direct care, that's a hear and treat call. And we've closed a number of those, more so than we have done historically, through really pointing people to alternate pathways of care, rather than a traditional blue light response to their doorstep, so to speak. We've seen a rise in category 1 calls. That's the most life-threatening calls, and we've seen that category 2 peak as well. However, responses for those calls are down. So while we're dealing with more people, physical responses, actual vehicles going to people, is actually on a slightly downward trajectory. Next slide, please. Thank you. So non-conveyance. So as we've discussed before, and as is very prevalent in the media, the issue of slow ambulance response times, ambulance delays, is not an ambulance problem. As we've discussed prior, it's a system-wide problem. It involves acute hospital colleagues, it involves social care, it involves discharge. It's a multifaceted issue that needs to be owned by all those different partners to reach a solution. The one thing that really is within our gift in terms of how we can help the wider Lincolnshire health and social care system is that non-conveyance piece, in that the less people we take to hospital, the more people that we can deal with in a community setting, in a virtual setting, in a signposting setting to right care, right place, first time, means it just takes that little bit of pressure off other colleagues to help out with those higher acuity patients. And what these graphs show from a hear and treat point of view and from a conveyance to an emergency department point of view is that improved position that we're seeing in Lincolnshire. And when you compare Lincolnshire against both the regional position and against the national position, we are a leader in that, and we are doing really well in terms of our keeping people out of EDs, emergency departments, where we absolutely can, reflecting the fact that they're busy, but reflecting the fact that it more often than not is not the right place for urgent care. It's the wrong place for urgent care, where fundamentally someone will have a poor experience because they will be waiting longer because they have not a higher acuity and there's other options available to them. Next slide, please. So this just shows over a greater time axis in terms of what that conveyance position looks like. And over the years that this shows, within the NHS Lincolnshire footprint, so that's not including North and North East Lincolnshire, Scunthorpe, Grimsby, we have had that continual decrease in percentage of patients that we convey to an emergency department. Next slide, please. So this slide and the slide after are purely graphical representations of the numerical performance data that's in the report that was circulated. So we can move on from this slide and move past the next slide. It's just for information. And one more, please. Thank you. So hours lost pre-handover to hospital. So just to explain what that means. So ambulance handover times nationally are meant to be 30 minutes, made up of a 15-minute period prior to the ambulance crew handing over and a 15-minute period for the ambulance crew to prepare to respond to the next call, the post handover period. And nationally, regionally and locally, we've seen these pre-handover times significantly rise as we've come out of COVID. Fundamentally, they've always been a challenge in Lincolnshire. We've always had winter peaks, but they have really rise significantly. If you just look at say the winter period of 2020 compared to 21 for those winter months, throughout the whole of 2022, we have been effectively higher than any winter periods in previous years. And that has a direct effect. When an ambulance crew is meant to take 15 minutes, it may be, historically that's taken, say, 30 minutes. When that's taking 4 hours, 5 hours in some cases, and higher, that only has an impact in response times because there just physically isn't vehicles around. And we work extensively with all the partners involved in that process, be that acute hospitals, be that A&E departments, be that the people phoning, so the public, GP surgeries, community care providers, to do all we can attacking that problem from multiple angles so that we're not on the receiving end, and patients fundamentally aren't on the receiving end of the delays that are happening with our acute trusts in terms of that handover position. The next slide, this slide shows the whole divisional picture. The next slide, if we move on to that, breaks it down for each of the acute providers that we work with. So NLAG and Northern Lincolnshire and Gull is effectively Scunthorpe and Grimsby's A&E departments. And this slide shows the effect that those lost hours are having on our resource outputs. And NWAFT and QEKL is Northwest Anglia, so Peterborough, fundamentally for us, and Queen Elizabeth Kingsland Hospital down in East of England ambulance dispatch. We don't take a vast amount of patients into Peterborough and Kings Lynn. However, between us and our Leicestershire divisional colleagues, we do take patients to Peterborough in quite a big number, and East of England clearly with it being their patch do as well. And we work very closely hand in hand with our East of England colleagues. My colleague Maria Stanley has regular meetings on an almost weekly basis, both with the hospital and with East of England Ambulance, whose area is, so that we're working hand in glove in terms of how we can get the most out of the problem to reach a solution for it and make it as efficient as we can. And next slide, please. And just to put that into a local context, for the NHS Lincolnshire area, this is the graphical representation of what those lost hours look like for ULHT for fundamentally Boston and Lincoln. We do take a small proportion into Grantham, but with its current clinical status, it doesn't really cause us problems in terms of big numbers in terms of conveyances or lost hours. That's fundamentally the performance piece. I'm going to hand back to my colleague, Sue Cousland, just to continue the final part of the presentation.
Thank you, Neil. That was really helpful. I'm moving on to the next slide, please, just to talk through sickness absence and how we support staff and manage through periods of sickness. The first thing that I would say is that our sickness absence rates used to be one of the best in the trust. Unfortunately, that position has deteriorated for a variety of reasons. One of which is that we do have a predominantly older workforce, and frontline physical 999 work can be quite taxing from a physical perspective. You will see that in August we did have the highest sickness absence rate. August is notoriously a high month or higher month, but we reached a peak this August, unfortunately. We have struggled with the number of staff who, unfortunately, contracted COVID as well, some of whom are still battling with long COVID symptoms. But again, we are supporting those members of staff. But I think it's fair to say that the performance and the issues that Neil has just outlined does take its toll on the members of staff who are struggling with the length of time they're often waiting at acute hospital. And also, despite our best efforts, when we are trying to get them off their shift at the end of the day, they are also elongated with their shift length of time. Sorry, I'm just distracted. My battery is just about to give in. It's my oversight on my part. I just need to plug in just for 1 minute. Just bear with me 1 second.
No problem, thank you.
Apologies, I was distracted there. I had plugged it in, but somebody's turned it off at the wall, so apologies for that. So sickness absence, as I was saying, is a real challenge for the trust as a whole, but also in division. We have regular meetings with staff as part of staff welfare and support, and we also report in directly to our Director of Operations on the progress that we are making in terms of managing that level of sickness absence. Moving on to recruitment and retention, the figures are there for you to see. A lot of the levers that we have related to natural retirement. We're losing a number of staff to other services, primary care being one of them. We're also losing staff to higher levels of training to become associate physicians, etc. So good for their development, but also leaves an impact for us. As a result, we are looking at it.
You've just started to break up a little bit, Sue.
The staff can rotate them through. Okay, I may put my camera off because the strength of signal in the office, unfortunately. So I'll just put my camera off. So, and the expansion of our specialist paramedic roles, I'm pleased to say that we are hoping to increase the number of specialist paramedics that we're going to have within the division. The numbers have yet to be quantified, but we're hoping to increase the current pool of 6 by at least another 6, and also to include a development role, not only for specialist paramedics, but also for those aspiring to become managers in whichever sphere they are interested in the future. So it's to give people further opportunities over and above working at frontline care. So next slide, please. Serious incidents. As you can imagine, the delays that we are experiencing as a result of some of the issues that Neil has just described means that we've had an increase in reporting of serious incidents in Lincolnshire. Since April this year, there have been 9 incidents reported in Greater Lincolnshire, which is 30% of the total number reported in the trust, and 7 in North and North East Lincolnshire, which is 23%. So as a division, we account for just over half of the whole number of serious incidents occurring within the division, within the trust. Having said that, we may take a little longer to get to patients, but through other metrics, it certainly defines the fact that when we do arrive, the quality of care that we deliver is at least on a par with that delivered across the region, if not superior. And we maintain that high level of clinical care quality at the front line. So I've already spoken to you about the new organisational structure, and you have Neil and Maria with us today. We have an expanded tactical command structure. So these are people who work 24 hours a day, and we have 4 of those on duty for the size of the county at any one time. And they are supporting crews who might be having some difficulty in finding the right pathways of care for patients when they do arrive on scene. We're looking at cohorting plans to make sure that we actually get members of staff off who are waiting at the hospitals at the end of their shift. And we're also looking at further ways to reduce patient harm. We've introduced the role of station managers. We have 9 across the county, 3 in each locality, and they are focused solely on staff support and well-being. And that role, I have to say, is really working very well, certainly in the eyes of the staff. We have 6 senior clinical leaders in the organisation and 6 associates as part of that development role. So we have 12 members of staff who are entirely focused on clinical care delivery. And I have to say, we're very proud of them in Lincolnshire because our clinical lead team won an award at the Trust's reward and recognition ceremony on Monday evening, and they were all in Leicester to collect their reward, which was a huge focus, a huge recognition for the level of work that they do within the county. And we've just undertaken a 12-month review of that restructure and fed back through to the Director of Operations. In addition, we have actually improved tremendously our working relationships with the entire system, but in the main with our community service colleagues and our acute hospital colleagues at ULHT. Next slide, please. Thank you. Just jotted down there some transformational achievements and some changes that we have brought about ourselves in Lincolnshire. We now have 2 pathway leads who are working tirelessly to actually find suitable alternatives to going to an emergency department. As Neil has already mentioned, it is not relevant for all patients to attend emergency departments. There are lots of other pathways that are more clinically appropriate. So our pathway leads work with a wide number of stakeholders in the county. Just picking out some of the other elements, we now have a mental health development lead working in the county with a dual role of actually training staff whilst they are at work around how to recognise and how to manage patients with mental health conditions. And also they work with our pathway leads on providing and seeking out new pathways for mental health patients that again would be more appropriate for the level of need and clinical care that they need. I've mentioned to you about the expansion of the specialist paramedic role. We're also looking at them providing a hear and treat role again, so that we can actually ensure patients actually get the right care as close to the call as possible. We do an awful lot with military engagement within the county as well, particularly with the RAF. And we do have a liaison manager, Rich Hunter, who is ex-Army himself, has just been down as part of deployment to help London Ambulance Service for the Queen's funeral. So he works very hard with particularly the RAF bases in providing further development for their medics as well, working with us. And Neil is our link with fire and rescue services as well, around expanding the work that we could do collectively in order to try to manage some of our acute levels of demand. So next slide, please. Nearly finished. Just to describe those strategic relationships that we have. A lot of this work is down to the role of the heads of operations and myself to build those relationships to ensure that we have a much closer working relationship. Happy to take any questions later on our work in any of these environments, but we are well connected and seen as very much an integral part of the system in Lincolnshire. That brings us to the end of our presentation. Thank you, and I'm happy, and the team is happy to take any queries or questions that you might have.
Thank you for that, and thank you for the presentation. I've got Councillor Allen first, please.
Thank you, Chairman. I would also like to thank the presenters for the presentation and the information provided. It does, in my view, provide some degree of concern, which has probably been identified within the presentation by the ambulance service people concerned, particularly in the Category 1 and Category 2 responses, which do, I think, worry in terms of the amount of time that's taken to actually deal with patients in those two categories, and particularly Category 2, and whether it's an emergency, whether it's Category 1 critical or Category 2 emergency seems to be a very moot point. I can remember ringing 999 a year or so ago, and the first question was, is the patient still breathing? Which seems to almost suggest that you move from Category 1 to Category 2 as if you say yes. That seems very odd in my view. But the thing that worries me more than anything is that the National Health Service response for dealing with these sort of situations from beginning to end, and the difficulties that seem to be occurring in terms of delivering the service that the people of Lincolnshire perhaps deserve and indeed need in certain circumstances, it seems to be well understood. If anybody's got an interest in healthcare at all, you can track the issues all the way from lack of beds and bed blocking, all the way through the arrival of the ambulance, and indeed all the way back to the ambulance turning up as a result of the 999 call. But there is no one that seems to be taking overall responsibility for improving that throughput whatsoever. The ambulance have got particular difficulties, do what they can to actually address those. Getting patients out of ambulances into the actual hospital is a major problem. And I say, it's all understandable why that is occurring. And we hear from the various parts of the NHS system in terms of delivering that throughput all the way through to hospital and treatment, and eventually returning them to returning the patient to the community, hopefully in a cured form. We hear all about the various issues and all the bits that they are doing to try and improve those bits of that delivery, and deal with some of the issues that come from trying to deliver those bits of that particular delivery. Indeed in terms of the ambulance service officers, finding better places to go and work or whatever it is. Or indeed, what seems to be happening on a prevalent basis within the National Health Service, of people that work in one part of the National Health, one part of that delivery, moving to another part of that delivery, because the jobs are better paid, or there's a promotion involved, or whatever it is. So there's a vast number of people just moving around the system without any overall increase in the actual number of people that's there to actually deliver the improvements. Change being put forward as a solution, training being put forward as a solution. But there is nobody that says this is what we need to do as a whole to deliver the process that's going to bring some improvements to the system and stop all these various problems at the various points of moving through the system. And that's what I find dispiriting. It is quite clear what the problem is, but nobody seems to get to grips with the problem as a whole and say we must do this to see things through to an improved situation. It's always, we can do this bit here, we can do that bit there, that bit there. And until we get to grips with the whole issues associated with dealing with patient care all the way through the system, I can't see any improvement taking place. It's not really a question, I'm afraid.
No, it's not. But I don't know if you can unpick anything from that, particularly Sue and team.
Yes, yes, I would like to, if I may, Councillor Allen. I apologies if it didn't come across as strongly as perhaps it should have done in the presentation. But when I say that we are a meaningful player sitting around the table with our provider and commissioner colleagues, looking at the system issues as a whole and not just looking at the ambulance delays at the front end of the hospital, that was what I was alluding to. The overall oversight is via the ICB, the Integrated Care Board. Claire Raybould, who is the Director of System Delivery, is also the Senior Responsible Officer for Urgent and Emergency Care. We meet once a week as a system of senior leaders to talk through. At the moment, we're looking and focused on winter priorities and schemes that we bring in every winter to help with the increased activity and demand across health and social care. So there are a suite of schemes related in particular to winter. We are reviewing as a system our urgent care strategy and how we work together. The People Board in Lincolnshire brings us all together, looking at recruitment, retention. Can we actually rotate members of staff through different organisations to have different experiences, to pick up different skills, and therefore enhance the retention of groups of individuals, but also, probably more importantly, their own knowledge base as well by learning from others. So we're very much not working in a silo. We're working collectively across the system, and I hope that goes some way towards giving a degree of assurance that the system works together and not in isolation.
I'm afraid not. And
Okay.
when the figures start changing significantly, rather than being on a rising, worsening situation, perhaps I will.
Okay, thank you. We'll move on to Councillor Smith next, please.
Thank you, Chairman. As Councillor Ann's already alluded to, I think part of the problem is actually, and this goes back to other conversations we've had in this chamber around other elements of the NHS. The NHS as was does not exist. How it was created does not exist. It is not a national health service. It is split into bits. So you have LPFT, you have EMASH, you have Nottingham Trusts. They're all separate trusts. They're all separate entities in their own right with all their own governance structures. They're all vying for money from a shared pot. The only thing that is the national health is where the money comes from, which is obviously the ratepayers. As Councillor Allen said, I mean, the mean target time is 18 minutes, but you're waiting anything between 52 to 2 hours. Let's be frank, Chairman, that if you've got certain conditions, that could have lifelong implications because it's taken that long for you to be seen. Now, I must stress, I've been in the back of an ambulance with somebody when they needed care, and the care that gentleman received was fantastic. That is not the problem. The problem, as has already been alluded to, is handover and actually getting there. You could argue this goes back to actually when Lincolnshire used to have its standalone service before it became EMAS. Actually, the problems were lessened because it had a smaller area and wasn't being taken out of county, but that's, I appreciate, above my pay grade and above many others. As Councillor Allen said, what is the advice really for residents? Because the advice I would always give, if you are tier 2, if you have somebody that can get you there in a vehicle, for the love of God, do it, because you will get there quicker. Okay, you might be in A&E longer, but you will get there physically quicker. Okay, that person that you're with doesn't have medical training, I appreciate, but if you can do it, unless the presenters say otherwise and that they believe medically you are in a worse state, my advice at the time to a resident, because this was raised with me recently, was get there yourself because you're going to be there quicker. What can we actually do to see improvement? Because we're constantly told that we've changed this, and there's improvement coming. And I have no doubt that EMAS particularly are working as hard as they can to get improvement. The problem is, as Councillor Ann's alluded to, the system simply doesn't work. Everyone's vying for money, everyone's vying for resources. People are moving through a system rather than an increase in numbers. As we've already heard, people, quite rightly, they want better pay, they want to be promoted, understand that. But it's not, the system is systemically not functioning and not working. And as Councillor Allen said, you can say it's not working in silo, but to an outsider looking in, that's exactly what it's doing. You may have these meetings, but it's not translating into real world improvement. And until that happens, as Councillor Allen said, it will see that it's working in silo. I appreciate there may not be a question in there, Chairman, but it's concern for my division when you think it goes as far as Swallow, which is near you're closer to Grimsby than you are Lincoln, and all the way to Bigby. What am I, and probably divisions on the East Coast as well, and others. What are our residents supposed to do? Are they better to wait 2 hours, or are they better to get in a car and go themselves?
Yeah, thank you, Councillor Allen. If I may, Councillor Smith, sorry, if I may just build onto it. I think one of the things that I had as a question later on, but it's building upon what you've said, is, we've had the Ambulance Trust in front of us now for many, many years telling us, they're doing these different things to try and make the improvements. However, we're only seeing that it's worsening. So what is being done differently now to improve it, I would have asked, and how confident are you that we're actually going to finally see an improvement take place?
So if I could just unpick a few elements of that, if I may. First of all, the reference to Lincolnshire Ambulance Service. I think Neil has eloquently described the much higher levels of activity that we are now dealing with in the county that we didn't have before. And I would just draw people's attention to the fact that we are hearing and seeing more patients than we have ever done before. We do know that patients will dial 999 if they have received a level of frustration about not being able to access healthcare anywhere else. And I would say that the staff, the senior team in Lincolnshire, are working extremely hard to try to keep those people who do ring us as safe as possible. We do identify people very quickly who do need blue lights and the expertise that comes with those blue lights, whether it be in a car or whether it be in an ambulance. We are nationally, the ambulance service is looking at separating category 2 patients into 2. So those people who are ringing with signs and symptoms of a suspected stroke and heart attack are looking to be given priority. And I would stress this is something that is still being discussed at a national level in recognition of the higher number of people who are now contacting the ambulance service. What we do need to do as a system is we do need to change behaviours of people. And actually, I've been on radio and television numerous times trying to ensure that the public are aware of alternatives to dialing 999 as a first option. There are a lot of other avenues within the county for people to seek advice. In relation to is it easier and quicker to take yourself? When we are really busy, and I was on call until the early hours of this morning for the whole region, and we had, at one point, we had over 50% of our available ambulances waiting at an acute hospital ED department to offload our patients. It is very, very difficult to actually get to people within 7 minutes to category 1. We do have an agreement with our acute hospital trusts that if there is a patient that is in that category 1 category and that we don't have anybody to send, we can offload a patient immediately in order to release an ambulance. Again, that is a national position and not just a local and regional position. So I'm really sorry if you're not getting the assurance from us, but we are trying very hard under very challenging circumstances to keep as many ambulances on the road and responding as we possibly can. But these are system issues that we need to work together, and indeed are working together. And I'm sorry that you're not seeing the results of that yet, but I am confident that we will start to see some improvements over the coming months. That being said, we are all bracing ourselves for what is being called twin fluenza, and that is the incidents of flu, influenza, and also a further round of COVID. So we are operating under extremely challenging circumstances. Neil and Maria, I don't know whether you wish to add anything else to that.
Thanks. So the only thing I was going to add in terms of that scenario of you phone up, you require help, and what do you do? I would say that both locally and nationally, we have changed the way that we take 999 calls with our 999 call takers. So there's a thing called a clinical safety plan that every ambulance service works to, and based on level of demand and level of capacity and weight and risk, that's set at a certain level. So previously we didn't do this, but now we do. So we will inform the caller as to what the current status is in terms of anticipated wait time for a particular category, so that they can weigh that up and make an informed choice if they so choose to do so, as to what is the best option for them in the situation they're in. That's not something we've ever historically done. We've never given wait times, so to speak, like a logistics company would, but it's something that we nationally as a sector chose to do and were directed to do, to give patients, callers that informed ability to help make their own risk-based decision as to weighing up the choices that they've got.
Yeah, thank you. If I may, I'm just going to comment at this point. Please don't think that we are, trying to say that staff aren't working exceptionally hard. We completely accept that. But, as councillors, I think, I've got a question I'm going to comment at this point because I think it's relevant to where we are. And that I have been actually contacted by two separate residents who live in the Skegness area. One who suffered a major heart attack and waited 6 hours for an attendance, and the second who presented at the UTC with stroke symptoms, to which an ambulance was called and after a number of hours still had not arrived, and therefore they had to rely on a lift to Lincoln. I think the point we're trying to get across is, do you feel you are operating a safe service? And in turn, do you feel confident that the implementation of the acute services review is now not going to lead to a potential loss of life?
Those are very difficult questions to answer because you've already heard that we are trying our best with the resource that we have available. We try to keep our patients as safe as possible. For those who are waiting, we are calling them back. We are advising that they ring us again if their condition deteriorates. For the two patients that you have described, I'm happy to take those details and look into them offline, because that's not what we're aiming to do. We are aiming to be with patients in those particular categories that you describe quicker, because we need to be, and we recognise that we need to be. I really don't feel that as an organisation we can offer any more, because I keep saying this is a system issue, and I wonder whether some of these questions need to be addressed to wider system colleagues rather than just us.
Thank you, Sue. Yeah, and we'll take that on board. It is questions we do and will be asking further, but I think it's always good to get the rounded view. Councillor Smith, will allow you to come back briefly, and then I've got a long list of others that want to ask questions.
Thank you, Chairman. Firstly, on the question previously, you missed the point of my question. The question was, in your professional view, is there a clinical, there's 2 points, is there a clinical benefit when the wait time is longer to get there yourself, as in clinical safety? Secondly, the point I made about East Midlands was, and I appreciate the number of calls have gone up, they're going to go up, population's increased. The reason I asked that question is because would you believe you would perform better if you weren't an East Midlands service, but you were a Lincolnshire specific service, as you were many, many moons ago before it changed? And as the Chairman's already alluded to, I don't doubt how hard you're working. The fact that you're giving wait times to me is deeply alarming, because what you're saying is, we haven't got the resource, you're going to be waiting for 6 hours or 3 hours, as the Chairman's alluded to. And if you haven't got that support, or you're in a position you're not able to, or you're stuck, the point of you wishing to split category 2, I'll give you an example. In my youth, I split my shin open quite badly. okay, it's not a heart attack. But if my late father hadn't been there, nobody could have physically picked me up, got me in a car. Okay, I may not have bled out, but the pain level for, I think I was about 6 or 7 at the time, would have been excruciating, and you could have now you could be looking at waiting 4 hours in pain, no pain relief, you know, and then be stitched as it was. And I appreciate, as you've said, these are system issues, and I can assure you, as I'm sure the chairman has already, we will ask this of everybody, and I must echo the chairman's view on the acute services review. I've got serious alarm bells ringing in my head that we are going to see people either have worse clinical outcomes or people may lose their lives. On a happier point, and I will be brief, Chairman, I am a member of the East Midlands Veteran Advisory and Pension Committee, and I'd very much offline like to speak to, I believe it was Richard who's involved with principally the Royal Air Force around their medics and things, in how we could, as a VAPC, how we could work together offline, if that's something you would be interested in. Thank you, Chairman.
Just picking up the last point first, Councillor Smith, absolutely, and I'll forward Richard Hunter's details to Simon Evans so that you can make contact. Picking up some other points, and apologies if I haven't answered as succinctly as I had hoped I had done. The question around were we more efficient and effective as Lincolnshire Ambulance? I disagree. I wasn't around in Lincolnshire Ambulance days, and I don't think Neil and Maria were in county either. What we do have as a regional service is the offer of mutual aid from other divisions that is readily available to us and used on a regular basis. We are what they call a net importer of resource. It's very rare that our ambulances go over the Lincolnshire border. It is more common for ambulances, particularly from Nottinghamshire, to come into Lincolnshire to help support. So in terms of efficiency, there is a lot more to be gained by being a regional service rather than a more district service. But I know there have been some conversations held with our Chief Exec, Richard Henderson, in relation to Lincolnshire Ambulance. It is difficult to actually say any more on the topic because I do feel that we are going over old ground. Neil has already articulated as part of our clinical safety plan, when we get to certain levels of activity and holding a certain number of calls, the advice to patients calling will change. And those patients who feel that they are able or have the ability to get themselves to an emergency department or an urgent treatment centre when it is indicated, they are advised to do so when we reach a certain level of activity from a safety perspective. So that advice is already given, and that is a national approach, not just an East Midlands ambulance approach. We all use exactly the same protocols for clinical safety.
Okay, thank you. In which case I'm going to move on to Councillor Ray Wootton, please.
Thank you very much indeed, Mr. Chairman. First of all, I must say thank you to the East Midlands Ambulance Service staff for all their hard work. I really appreciate what they do, and I'm sure members of the committee do as well. The 2 points I want to pick up in first is the fact that people can't get any access to their local GPs to get advice if they need any treatment. And secondly, can I also tackle you on the ULHT handover, because compared to other authorities, they're higher. Is there any evidence to suggest that the overnight closure of Grantham Hospital has contributed to more people going to Lincoln Hospital than might be available at Grantham? Thank you.
Thank you, Councillor Wootton, and it's nice to see you again, and I appreciate the thank you that you have just given to the staff. In terms of GP advice, we do a lot of hear and treat. So on occasion where people have not been able to get to their GP and use us as an alternative, that is where our clinicians come in to being. We have a doctor in our emergency operations centre who is able to talk to patients alongside senior clinicians to find the best alternative option. Unfortunately, I can't comment and wouldn't be in a position to comment on GP accessibility, but we do try, where it is more of a GP related issue, to actually work with patients using our own doctor, and we are able to book appointments directly with certain practices as well, and also via the clinical assessment service in LCHS. So we do find alternative avenues where that is the case. In terms of ULHT handover, it is recognised by the system that we are waiting for quite long periods of time on occasion. Again, we work very closely with senior colleagues in ULHT. They do try to turn us around as quickly as possible, and the system has just funded, and we are about to appoint to some senior personnel who will work at the front end of A&E departments on a permanent basis to be the interface between the ambulance service and the hospital, in an attempt to get ambulances turned around more quickly. And we're hoping to have those posts filled ahead of winter, certainly by December this year. So again, a couple of points that I hope go some way to be helpful.
Thank you, Chairman.
Thank you, Councillor. And I've got a list of 5 speakers, so I'm closing the debate now. So I'll start with Councillor Parking.
Thank you, Chairman. I think what concerns me is we're rightfully looking at EMAS, and you know it's been an issue for as long as I've been here and attending meetings in this chamber, and before then. I too would like to pay tribute to the staff. I wouldn't want to do that role, and I admire them immensely. I think what I am concerned about is this idea of it being a system-wide failure. And I think it would be really helpful to get some context from the hospital trusts also about what they are doing in terms of handovers to facilitate it, because we're looking at one end and not the other. So I'd like to kind of suggest that potentially for a future meeting, and for us to get a better understanding of how those two are relating to each other. I'm concerned about, everybody's concerned about funding for the NHS, and I'm well aware that, you know, without harking on and making a political point here, that we have national issues as well that we are kind of contending against, and I think all of that is creating a perfect storm. One of the things that I think we can look at as a council response and councillor response, and it was a discussion that I had at my parish council this week. Unfortunately, my mum had a fall a couple of weeks ago, and we rallied round as a family, obviously, to give support. She had excellent treatment from Lives immediately after the fall, and then we rallied round as a family to help care for her the next day. But one of the things it's really made me mindful of is in terms of falls, my mum would kill me if I called her elderly, with more mature residents, is are we helping them risk assess their homes? Are we getting messages out there that could stop those incidents from happening? Is there more that we can do in terms of a public health message? Is there more that we can do with our parishes, with our town councils, about helping people understand how to stop some of those incidents happening, whether it be gardening accidents, whether it be people falling over? I think there is a discussion there to be had with our communities, not necessarily phrased around don't get injured because no one's coming, but I think we can come with a more constructive strapline than that. But I do think there is some conversations that we need to have with our communities and with our parishes on that side of things.
Thank you, Councillor Parkin. I was smiling merely because I have a mum who would also kill me if I ever referred to her as elderly. I'm going to hand over to Neil in a minute, because I think the points that you made in relation to falls are extremely appropriate, and I think there is more as a system that we can do, and indeed we are doing. I'm going to ask Neil to describe a pilot recently with ourselves and LCHS and what's happening as a result, but also making a reference to the live service, and also how do we integrate more fully with that service, and also with social care colleagues around that assessment, that trip, slip, hazard assessment, and how we can prevent, because we know the evidence suggests that once somebody has fallen, they become more vulnerable then. But I'll just hand over to Neil just to outline the recent trial that we did with LCHS.
Yes, certainly. So falls absolutely has always historically and remains to be in the top 5 for us in terms of reasons for calling or incidents. And that can be everything from, literally a long fall with multiple injuries to a fairly simple fall with low-level injuries. And while it's a high-volume complaint or incident, unfortunately, when you've been triaged and you're in that lower priority grade where it's minor to no injury with a fall, with, as we've described, the demand we've got, that just the reality of that is that's never going to be a speedy response. It's never going to be the top of an acute life-saving risk. So within Lincolnshire, we've always looked at falls in terms of what can we do differently, because fundamentally, what does most people need when they've had a low injury, no injury fall? They need a community response to assist them. That doesn't need to be an ambulance. And we've certainly worked with multiple partners in the past in terms of what does that look like. The most recent piece that we've done with Lincolnshire Community Health Services, we embedded one of our senior paramedics into the LCHS operations centre, so we can both view each other's activity in real time. And it became very apparent that while we do have, for example, the Lives Falls service commissioned in conjunction between the ICB and Lincolnshire County Council, there is still a significant proportion and population of those lower priority calls that could be dealt with differently. So we're just in the sort of final stages of discussion with the urgent community response teams, which is nurses, physios, OTs that provide that community response through Lincolnshire Community Health Service, in terms of sharing our activity workload so that they can effectively cherry pick some of that work from us, where the patient needs a response, doesn't necessarily need an emergency response. And we're hoping that will have both a better patient experience outcome for the patient, because fundamentally they just want the help. It doesn't matter in what guise that help comes, but also will help us in terms of managing that higher activity that we're sitting and holding case loading on a daily basis.
Councillor Parkin.
Thank you, Carl. I'm just wondering, because of our roles in terms of supporting parishes, is there more that we can dig around with here in terms of getting information to them about how people can risk assess their own homes and their own risk of falling, and if loose carpets, rugs, that kind of thing? Whether we work with adults on that as a piece of work, just so that we can get maybe something out to council development about getting a message out to our communities.
Thanks, Eric. Yeah, I'll have a word with Simon, because obviously he sits over adults as well, so we've got that link there, which I'm sure we can pull something together. And in terms of what you were suggesting about having the hospital trusts here to sort of look at over, the handover delays, I actually think we need something bigger than just the hospital trust. We need the ICB, because they are the cords that pull it all together. So thank you. I've got Councillor Overton next.
Thank you, Chairman, and thank you very much indeed for the presentation, and I do appreciate the hard work. I had a really good ambulance person in my community who is one of those who stopped because he found himself so much in other parts of the East Midlands, actually. So I'm interested, and then a very long time to get back. So a long time to hand over, and then a long drive back, and then crack of dawn the next day. It's just not practical for people, because so I think that's the signing off time was well before his opportunity to get home, and I think that's another issue. You said that not many ambulances were leaving Lincolnshire, but that's at odds with what people tell me locally. So I'd be quite interested if you've got some figures to have a look at that. You probably have, but it would be the issue, and maybe it's the same people that always get picked to leave the area. Perhaps there's something in that, but it seems to me that that's part of the reason, as you raised, also part of the reason why the job becomes untenable for individuals, and we lose really good people from the profession. So I'd just be interested in that. And also on the graphs you gave, I couldn't quite work out what the scales were. They're not labelled, so it's probably because I'm new. But I don't know if you could just say, and I don't know what time period it is. For example, the Links Division lost hours, pre-handover. What is the average currently on that one? Thanks a lot.
Councillor Overton, I'll hand over to Neil because I can see him looking. If he can't give us the drift figures in the meeting, we'll certainly forward them to Simon Evans. In terms of the end of shift, just to give some assurance, we do have plans at the end of every shift where we have a crew or crews waiting at hospitals. Unfortunately, we have 5 acute trusts that we service who often have delays. So that means sending 5 sets of staff to 5 hospitals on occasion. But where somebody has been delayed, they leave. There is an 11-hour gap for safety between the time that they finish and the time that they are expected to come back on duty the next day, which is something that is unique to the ambulance service. As a nurse by background, there is certainly not that level of protocol attached to certainly nursing shifts on the ward or in emergency departments, for example. So just to give you some assurance on that. And also the fact that, do we send the same people out of county? No, unfortunately, well, fortunately, it doesn't work like that, because it is the next allocated vehicle to become available if we do have to send people over the county borders. Generally speaking, the main reason that our ambulances leave Lincolnshire is to take patients for more specialist treatment, either in Nottingham or Derbyshire in particular, or further afield. So Neil, I don't know whether you wish to come back.
Yeah, certainly, and apologies on the data access piece. From conversion over, it's cut off, but just to highlight that verbally, I think you're referring to slides 12, 13, 14. So the left axis is number of handovers over 60 minutes. The right hand axis is total number of lost hours. So that's what the axis is for those ones. In terms of the drift hours, now drift is number of hours that we receive from other counties into Lincolnshire or the reverse. I can't provide that now, but I'll certainly provide a written response to that to give the detail of what that looks like over a historical trend. And just following on from Sue's point regarding out of county work, again, it's not repetitive. However, there is a bit of a geographical twist to it in that clearly our staff that work out of, say, Stamford will spend more time out of counties because of geographically where it is than, say, our staff at Mablethorpe. But there isn't any more nuance to it than that.
If I just come back, thank you. I think the issue is that if Lincoln doesn't have the ability, as you say, specialists, but so many more of our cases now are requiring good, specialist support, and that's why they have to travel to those out-of-county areas. So it's not that they shouldn't, it's just that it does mean it makes it very difficult for them to get back. And your 11 hours is taken, the gap in 11 hours, but of course the person has to drive home. So if it's from Leicester, that could be another hour in each direction. So thank you.
Just to clarify that point, if I may, that is from the time that the person finishes their shift and delivers the ambulance back to the ambulance station that they are based in. So we don't take into account the drive home.
Thank you.
In that calculation, just to give further assurance.
Okay, thank you. Councillor Chalmers.
Thank you. Having listened to a number of conversations in the hall here over the last few months, it seems to me that there's a problem in almost like a circular motion. We spoke recently with one of the hospitals that said that one of the big problems they had was discharging patients in order to clear the backlog and admit patients in A&E, and the discharge process was held up by the ambulance service, who are also responsible for bringing people, moving people and relocating people. So it feels like that there's a need for greater communications between all departments, and that they're getting pulled rather than actually making decisions. And we all know if you go with the flow, you end up at the waterfall and you crash and burn. There seems to be a lack of structure somewhere that could be improved with greater communications. Also, we spoke about, we've looked at the figures and it was said that we're looking at recruitment. Well, there's a shortfall of 16 members of staff, and some of those, the first reason was listed was retirement. So we've lost 16 people. And with the word retirement, my assumption is that they were key members of staff with a lot of knowledge internally. Rather than just looking at it, what's being done to recruit and re-recruit and fill those jobs, because that's essential to drive the entire service in the correct direction. And do we actually have enough vehicles? So, sorry, there's lots there. Councillor Macy, your stories sent shivers up my spine. I got goosebumps. But because I can relate to it, and how horrible is that? We had a patient who contacted me. She'd spent 10 hours in an A&E after a stroke in Boston, waiting to be transferred to Lincoln because she couldn't be admitted into Boston because they hadn't discharged people because the ambulance service couldn't take it to Lincoln and couldn't take people out of Boston Hospital. So again, it's all that there's a whole cycle of mess that needs to be unpicked.
Again, if I may come back on a couple of those points, apologies if I didn't quite capture them all, but the discharge transport is TASL, not East Midlands Ambulance Service. So again, that is picked up on tactical calls where there are difficulties in arranging that discharge transport, but that is not our responsibility at the moment. In terms of do we have enough vehicles, we believe we have there or thereabouts the amount of vehicles if we have the right number of staff on duty. So I referred to our sickness earlier. If we have the right number of staff and we are able to drop patients off and leave the hospitals within the timeframes that Neil has described, we know that we can do it with the number of vehicles that we have available. Because we have proven that on occasions. In terms of the recruitment and retention, Councillor Macy, I will provide the new recruits that we have recruited. So newly qualified paramedics and newly qualified technicians over the last few months, so that you can see that we are managing to top up the number of staff that we should have within division. And we've just recruited the largest number of newly qualified paramedics that we have ever had in Lincolnshire, but I will provide those figures for you separately.
Thank you. Okay, I've got Councillor Harrison first and then Councillor Rice-Oxley afterwards. Thank you.
Thank you, Chairman. My interest is mental health and potential suicide patients. How you respond to them, which category you would normally use, because I'm sure it must have a big influence on the amount of time that your crews spend with people. Thanks.
Yes, they do, Councillor Harrison. Just I have to say, one of the great innovations of joint working recently is the mental health assessment unit that's opened up at Peter Hodgkinson Centre. Whereby our ambulance crews are able to take patients who meet that criteria for acute assessment rather than going through an emergency department, which gets them straight into that more specialised care. The level at which that type of patient are categorised depends upon the information that's given at the time of the call. But we, as I've already mentioned, around mental health development within the county, we are looking at further training for our staff on the road to be able to assist patients more readily. because they are not mental health experts. And where we monitor the time on scene that an ambulance crew might spend on scene, where there are particular mental health challenges that are outside our sphere of expertise, we do have good links in with particularly LPFT colleagues to be able to provide more ready assistance. So hopefully that gives some assurance around the focus on mental health and the developments.
Yes, thank you, because I'm sure it's something that my members and colleagues would be interested in. Thank you.
Thank you. Councillor Rice-Oxley.
Thank you, Chairman. Thank you for having me today. Thank you also to the presenters. You're clearly fighting some quite difficult inbuilt challenges. Here, 2 questions, if I may. First, recently I know of a suicidal person, just build on your point, suicidal person who was told that the mental health crisis team was not available, so they had to call an ambulance or go to A&E. And of course, sometimes people, if they can't access GP services, they're told to do the same thing. So I'd like to know what the presenters think. To what extent is the breakdown in the wider system hindering your attempts to improve your own service? And where in the system would you start the fixing to have the greatest effect on that? Secondly, just to build on the recruitment and retention point, so obviously the figures show that the more staff members are leaving than joining. So is that having a significant impact on your path to improvement? Is it a symptom or a cause of the difficulties you're having? So are more people leaving the service than you would expect due to the challenging circumstances in which they're working, or is you know, are these figures what you would expect for this time of year? Thank you.
Again, picking up in reverse order, so our retention figures, we work to a figure of 8% of our staff on a monthly basis. We have been consistently under that figure until the last couple of months, where we have been slightly over, and by slightly over, I'm talking up to 10%. So again, with the number of people we are recruiting who are newly qualified into both paramedic and technician roles, I'm confident that we are able to keep up with that figure of 8%. That being said, with newly qualified personnel comes with some additional support that is required to ease them into what is a very challenging role, and nothing in the classroom and indeed in practice hours can often prepare you for flying solo. And I remember those days of being a student nurse one day and a staff nurse the next, how difficult that transition is. So again, we are looking towards our more experienced members of staff to help support those newly qualified personnel. And I am confident that we will be able to expand our specialist paramedics, so our more experienced cadre of individuals within the county, with an associate role for those who aspire to that level of clinical delivery. In terms of the previous question, I think Councillor Rice-Oxley, if I captured it correctly, because there's a number of questions coming at any one time, the greatest fix for, where would we apply our greatest fix for mental health service provision? Is that what you were asking us?
Thank you. Well, it's sort of the wide, I mean, that's just an example, but we all know of examples where people haven't been able to access either GP, or in this case, it was the mental health crisis team that would normally assist with someone who is suicidal. Mental health crisis team would normally go around to the house in the first instance, as you know, and assess. So if that team isn't available and they're told to call an ambulance because maybe the person with them isn't medically capable or physically capable of preventing a suicide attempt, they say call an ambulance. So I'm just wondering what you think about what I mean, the wider system. So do we need to make sure that the mental health crisis teams are operating correctly, that the GPs are able to deal with what the GPs should? I feel like everything is coming to you. Does that make sense? When things break down elsewhere, everything comes to you, and you're being expected to deal with all this. It seems impossible, really.
Yes, and I think that articulately describes what happens to us on occasion. We do become the backstop because we are available through 3 digits, 24 hours a day, 365 days of the year. So the biggest fix for us in terms of what you describe is actually putting a senior clinical decision maker as close to the initial call as possible in order to assess and triage that particular call to make sure that we can channel it to the most appropriate care delivery at that point, rather than that patient experiencing a number of handoffs. And I go back to our doctors in our emergency operations centre, and also the expansion of those senior clinicians who we're training to work remotely to be able to contact patients directly once they have contacted us, to discuss in more detail what their clinical needs are, and to provide either appropriate advice and discharge, or signpost onwards to effective pathways that will help them. So that for me would be, or that for us would be, the biggest fix, that senior clinical triage and decision making right up close to the call.
Thank you. In which case, I've got one final question, and that is, the report refers to volunteer responders attending 10% of life-threatening calls. On page 13, this is found. If they arrive first at these calls, do they stop the clock in terms of the performance indicator, or does the arrival of an ambulance stop the clock?
Neil, would you like to pick this one up?
Certainly. So for C1 category calls, the most life-threatening calls, then yes, they do. But for the other categories, then that requires a conveying resource, to use the technical language, for an ambulance in plain speak.
Okay, thank you for that. In which case, I'm going to move to a proposal, and I propose that we thank the staff of EMAS for their continued hard work, that we note the information presented by the East Midlands Ambulance Service, and to welcome the continued collaboration with the Clinical Assessment Service, the Urgent Care Response Team and Mental Health Services, that we strongly encourage the work with acute hospitals to improve the timely handover of patients to their care, and seek a further report in 6 months' time. Do I have a seconder to my proposal? Councillor Linda Woodson. All those in favour, please show. Thank you, that's carried unanimously. And I'd just like to finally thank our presenters this morning. Thank you for your time. Thank you. In which case, we'll now move on. Okay, on to agenda item 5 now. Ashley House service change. This item was circulated as part of the agenda pack on pages 23 to 45, and I would like to welcome our presenters via Teams. Andy Ricks, Chief Operating Officer for the NHS Lincolnshire Integrated Care Board, Chris Higgins, Director of Operations for the Lincolnshire Partnership NHS Foundation Trust, and Pete Burnett. Okay, and I'll hand over to you just quickly to run through, and we'll take questions at the end. Thank you.
Thank you very much, and thank you to the committee for extending the invitation to enable us to come and discuss the paper with you, which is about the service change that is being proposed to Ashley House. If I just give a bit of an overview about the direction of travel for the future care of people with mental health conditions, and what has been historically an environment where people are cared for in hospitals or residential type settings. It's very clear over the last few years that the direction is to care for individuals in what we call the least restrictive setting. We're working hard to develop our community teams, to develop our community assets, to expand our transformation program so that people can access services in their local communities as close to them as possible. And certainly when we've discussed our Transforming Care cohort of individuals before, there's a real drive to get people back to as close to what we would call a home life as possible. And whilst that approach is one that we are working hard on and pushing for, the specific situation about Ashley House is that I guess an opportunity came forward to look at the model of care that we afforded to this small group of people. So I'm going to let my colleague Chris Higgins give some of the detail and the context and the journey of that, and then I'm sure there will be a number of questions, but one of the most important being around the consultation process that we are proposing to undertake. And our view is that this is not a significant change when one applies NH England's bed test. And that can be quite a technical thing to get into, but Pete Burnett knows the rules of this inside out, and I'm sure we'll be able to illuminate our view of why we believe that this is not going over the threshold for a significant public consultation. And our recommendation and hope is that you will support our recommendations to follow the consultation as we have set out in the paper, and obviously to take any comments, observations, or any other matters that are of import to the committee. So on that, I'm going to hand over to Chris. Thank you.
Thanks, Andy. Yeah, Chris Siggins. I'm a mental health nurse by background, worked in Lincolnshire mental health services for over 20 years, inpatient and community, and moved into various roles and found myself as director of operations. So I am familiar with the services we're talking about today. I've worked in the services we're talking about today, so just thought that'd be helpful context in terms of where I'm coming from. Also, I think you'll have the detail of the paper, and I won't go over it all, but I think it's just worth just drawing out who we're talking about here and how this group of patients might be different to other groups of patients that you might be familiar with. So we are talking about a group of patients who are in a rehabilitation pathway, and the patients that would normally be admitted to Ashley House, and it's a twin unit, Maple Lodge. It's what we call a low dependency rehab unit. So it's at the end of a episode of care. For some people, that can be quite a long episode of care. So they may have been in secure settings and spent a long time in a hospital environment. So it's really important that people are supported to transition out of that in a safe and controlled way, to build those life skills so they can maximise their independence. And that's often focused around coming to terms with living with a severe and enduring mental illness, what that means for them and the family, and how they can live their best life. And often that is about an integration back into society, having been outside of society for such a long time. So Ashley House is at the end of that pathway, but what we've known for some time is that there's been a bit of a drop at the end of that, a bit of a gap in services, that you are supported in a 24-hour inpatient environment, and then there's nothing beyond that other than routine care. And so what the community rehabilitation service does, and that's why NHS England have been really keen to see that implemented across the country, is to fill that gap so that there's a stage between just going from 24-hour care into routine weekly appointments. This is a service that can provide really intensive support out of hours, 7 days a week, into people's own homes, and can provide that transition and support into community for people in their own environments where it makes sense for them. So that's where it sits. That's different to other parts of the pathway, like the crisis pathway that was referenced in the previous item, where people in a crisis for mental health and then maybe go on to be admitted into an acute mental health ward. That's a different part of the pathway, and it's a different set of needs. Sometimes patients who've been through that episode of crisis and an acute need may go into one of these units, but it's just to make them emphasise the point, it's a latter stage of that treatment pathway. So Ashley House specifically, what I would say is that we've been looking at community rehab services a while. We had a small service set up in a part of the county when things started to hit in terms of COVID, and we had to make some decisions around our staffing situation at the time. I think everybody's familiar with the pressures the NHS was under in terms of staff availability, and we had to look at consolidating services to maximise workforce availability that we had at that moment. And so Ashley House was temporarily closed back in February 2021, and it was chosen because it was going to have the least impact on the least number of patients, and the best impact in terms of being able to release staff to help and support in other areas. And we're really confident in the community model that we were developing through community rehab. We felt really confident that the patients who were in there at the time could be supported in a safe way in the community. So it was a risk-based decision that we made and implemented. And we've been running that model for some time and are able to increase the capacity of the community rehab team, and we've been successfully delivering that for some time. And when I say successfully delivering that, what I would say is it's based on three factors, really. Is all the patients that were previously supported in Ashley House have been supported in an appropriate environment, either in the community, in their own homes, wherever that may be, or in Maple Lodge, which is the twin unit. no patients have had to be admitted into any other unit that would need that service previously, so they've not had to go to another hospital or outside Lincolnshire. We've managed to take care of all their needs, either in Maple Lodge or in the community. I'd also say it's been successful in terms of the feedback we've received. Patients, carers, our own staff are saying this is a great way of working, this feels much better. And we also know that when we done the engagement around this and other pieces of work, is that most people are saying, I'd rather be supported in my own home, at my own convenience, in my own community, rather than being uprooted and taken to hospital. And only when it's really absolutely necessary would I want to be taken into a hospital environment. And this model offers that for more people, an opportunity to be cared for at your convenience in your own home. And so on those kind of 3 tests, this seems to be looking like a really, really good model. Also aligns, as Andy's just set out, in terms of the long-term strategy for the NHS and what we want to do locally about treating people in their own communities in least restrictive environments. So where we find ourselves now is in a position where 18 months on, the beds just don't appear to be needed in Ashley House. If we opened it today and kept that community rehab service open, the beds would remain empty. The need isn't there because the community service is supporting people in such an effective way. And so that appears to be the case. We're really confident from an operational clinical perspective that is the case, but we really want to now opportunity to test that out with the community and the people in a more formal way. We're also clear that we know we've got other patients in other pathways that are outside of Lincolnshire and in other environments. And we're saying if we really expanded the community rehab team and really maximised its benefit for everybody in Lincolnshire, what could that do? And we're really hopeful that we could add benefits to other areas so that we could free up the pathway, help people to spend less time in hospital in those rehab wards, and that in turn would allow us to create more capacity to be able to admit people from out of areas. So there are some real clear gains at the moment that seem to be coming through, and there's other opportunities if we really expand the service out. So we've got to a point now where we're at 2 options really, which is, as we set out in the paper, is we carry on doing what we're doing and really bolster community rehab and maximise the benefit and see what more it could bring, or we stop doing the community rehab, drop it back down to its original form and reopen Ashley House. Now, what I would say from a clinical perspective, that would mean we're putting people back into hospital who don't necessarily need to be there, and that doesn't feel right or from a clinical perspective. And so we've got to this juncture where we need to make a decision about where we go next and what's the long-term arrangement for that model of care, and hence we're proposing a consultation to really find that out and stress test that with the people that use the services and other stakeholders. So I'll hand over to Pete and he can talk a bit more about the actual process consultation.
No, thanks, Chris, and thanks everyone for inviting us to the committee. So as you can see at the end of the paper, there's been in the appendix, I think it's C, there's been extensive engagement on the service since 2020 all the way through till this year in terms of what that model should look like, and workshops taking place. And as Chris and Andy have said, the proposal is in line with the national guidance and long-term plan around mental health services and aims to bring people obviously back into the community so they're treated at their homes, and actually the travel around this is as minimal as possible. Clearly, we have a legal responsibility to involve the public and stakeholders in decision making, and we truly want to do that in this process. But because of the service has in 3 years had 52 people go through it, we see it as more of a targeted, locally led consultation with those key stakeholders, including yourselves, the patients and the families of those patients and carers that have gone through that service, both those that are existing in the service model, but also those that have gone through it previously, rather than a kind of full-blown kind of public consultation, say we had with ASR last year, because of the kind of unique nature and the small number of patients that go through this in that sense. So as you see, the paper sets out a kind of approach to both publicising the consultation, trying to get as much engagement in this process as possible, along with 11 consultation events, both with staff but mostly with the public and stakeholders going forward. And we aim to try and, if the committee agrees, that we'd run that in January, starting in January. We want to avoid the Christmas period, where I think it's acknowledged it's not always as ideal to get feedback. So run it from January into March for a 10-week period to really consult and get the feedback on the services from those who really understand how the service operates and have used it and have gone through the kind of the new model and the old model going forward. And you'll see at the start of the paper, there's there's a consideration for the committee to determine. So within NHS guidance around service change, there's two processes. We can either do something locally, working with yourselves in terms of making sure that consultation is correct. So one thing we want to do is make sure, actually, once you've seen that, what else can we do, and what else you want us to do to try and bring that to life if you think that is the right approach. But before then, we need you to make a decision if you consider this substantive service change, because if you do, it's the role of the Health Scrutiny Committee to determine that change. And if you do, then we have to go through an NHS England process to go before we can get out to consultation, much like we did with ASR. So obviously that's a more significant kind of workload before we can get into the NHS England process. So even that process itself, with just actually once everything was ready, took 10 months on ASR, plus the work beforehand. So that would, if that's the right thing to do, we will do that, but that will elongate the process. So you're looking at, I'd have thought, at least a minimum of 2 years before we'd go out to consult. If you don't think it's substantive service change, and we don't, because like 52 patients have gone through this in a year, so it is more of a localised service, and it's in line with the NHS kind of guidance. We'd want to run this consultation, and therefore we want your feedback on actually the consultation described. Is that in line with what you'd want? Would you want us to go further and deeper in that? Because we can certainly do that and work with you on making sure that's right. And the aim is to obviously come back and work with you to say what the end of the consultation is, and is it the right thing to take forward. But before then, actually, it's all a moot point if you think it is substantial service change, and we need to go through the NHS England process, because we'll have to start that as of today and work through before we come back to you, read the public consultation.
Okay, thank you all for your presentation. Councillor Raywotton.
Thank you very much, Mr. Chairman. Once again, this is another service that we're going to lose at Grantham, although it may be cost effective for the service, but to me it goes against the 5 principles of the Mental Health Act, which is respect and dignity to patients. Can you tell me, do we still use the Manthorpe Centre for treatment? And also, how many of those 15 units that we had were secure units? Thank you.
I'm happy to answer that one. So just in terms of the first observation, absolutely respect and dignity come into everything we consider when we're looking at alternative service models and the current models we deliver. And whilst it's recognised that I think it's probably around 5 people a year may have to travel a bit further to access inpatient care of the type that's provided at Ashley House, equally there's a greater number of people in other parts of the county, Skegness, Boston, other areas that are going to travel less. So that overall there's a greater benefit to more people, as we've worked out on the profile of patients over the last few years. And as for the specific points about Manthorpe Ward, there are clinical services being provided out of there. We again, it was a unit that we worked with system partners because of pressure in the system over COVID, temporarily closed that as an inpatient unit, but there are clinical teams working out of there, not operating, as we've spoke to the Health Security Committee before. We have not operating the inpatient model at the moment. We're still running a pilot model around that, and a paper will come back at some point in the future to the committee to be able to consider the future options around Manthorpe. But there are staff still based in there and working out of there to offer clinical support on a range of different services. In terms of the secure unit, I'm not quite sure the question. I think the 15 beds, it's a single unit at Grantham is Ashley House with 15 beds in it. So it could take 15 patients at any one time, and that's what we're talking about. If I misunderstood the question, then please let me know.
Thank you, Chairman. My question was, out of those 15 beds, are any of them secure beds? Thank you.
No, thanks for clarifying. No, they're not. They are the most low secure of inpatient services that we have in Lincolnshire. They are open. So if you walked onto Maple Lodge today, which is the same unit in Boston, you'd find that during the daytime, there's not many patients in there. We encourage those patients to be out in the community. That's the nature of community of rehab, is getting out and involved in community activities. Hence why community rehabilitation works really well, because it's doing that work in people's own homes and own communities, rather than people going out and just sleeping in a ward and having staff around. Don't get me wrong, there is a need for inpatient services for some people. Some people need that round-the-clock support. But what we're seeing is that with that enhanced community support, it's a lot less than it was before.
Thank you, Chairman.
Thank you. I've got Councillor Linda Wootton.
Thank you, Chairman. Firstly, thank you very much indeed for the report, which contains an awful lot of information. But I note in 2019, funding for a pilot scheme for community rehabilitation was noted for 1/3 of the county of Lincolnshire, which you now want to extend further. However, in spite of being in lockdown and in a pandemic, in 2021, the 15-bed unit was temporarily closed in Grantham, a term very familiar to us members from Grantham. These staff were redeployed. Can you tell us what percentage of these staff, if any, have now left the organisation? This decision to close Ashley House, to me, is centralisation and using the staff to help out with shortages of mental health staff elsewhere or to work into the community rehab team. I care deeply about people with a mental health condition, as do many of my colleagues here. I ask you, as stated in the report, if coming from a locked unit outside of Lincolnshire, and the pilot is only for 1/3 of Lincolnshire at the moment, where will these people get picked up? i.e., where will their care be dealt with? If people are signed off too early and out in the community, they often stop their medication, which happens a lot. How often will their mental health worker make contact with them? And can you tell us what sort of a caseload any mental health worker would have at any one time, please? And within the National Mental Health Plan, £2.3 billion has been committed from the government. Hopefully, Lincolnshire will bid for their share of this money to recruit more staff and help out with the national shortages for mental health workers and give us more facilities. That's my question. Thank you, Chairman.
Thank you, Councillor. I'll try to think I've got most of them, but apologies if I've missed any of the key questions you asked there, but I'm happy to run through those and hopefully I can pick up the queries you've got. So firstly, the staff that have been redeployed, as far as I understand, nobody has left the organisation. All those staff were successfully redeployed into other areas. What we found, which is kind of covered in the paper as well, is that some of those staff have really loved where they're working and have chosen to take up substantive contracts in the bases that they're working, which does cause a slight issue if we decide to reopen the unit. That some of the staff have gone to work in other roles in the trust, so we'd have to recruit into those vacant posts. But that's a positive that they've stayed within the organisation and found enjoyment in the roles that they've been redeployed into. The other question about the transitioning from locked community, absolutely. We're not taking any elements out of the pathway, so we've still got that all stages of the pathway. What we've done is added to the pathway with this community rehab team, and that means that we can ensure that everybody gets the appropriate level of care that they need. So I'm absolutely confident that we can offer the right level of care and support for people in the current setup that we've got now, and there is capacity to do that within the services we've got. The issue around discharging too soon also could be flipped on its head in terms of sometimes we don't discharge soon enough. There's a tendency in mental health services for people to stay in inpatient services longer than is necessary, and that creates a dependency and an institutionalisation that can be really unhelpful for people moving into independent living. And so it is a balance to be struck that has to be decided through careful consideration with individual families and with the clinical teams. But absolutely we make sure that people stay for as long as they need, but we wouldn't but it's also making sure that people are maximising their independence and able to live fulfilling lives. Just in terms of the detailed points at the end around context and caseload, is the idea with the community rehab team, it will potentially be daily contact if people need it, maybe several times a day. It's being geared as a service that has a low caseload. So I think it's referenced in the paper that probably about 60 on the caseload for quite a large group of staff. And what they operate is, rather than individual clinician caseloads, it'd be a shared caseload where they all come together and make sure there's absolute intensive support for extended hours and several times a day if it's needed. The idea is that as somebody first comes out of hospital, we'll be preparing, daily support, potentially several times a day, but we'll be able to drop that off as they feel more confident to care for themselves and in their own communities. So the caseload has been designed to be a low caseload with a high workforce, so that we can provide that intensive support.
Pete, you want to come in?
Yeah, and it's just to say, I think the key to this paper is actually we want to really harness what the patients and their families who have gone through the service over the years and are still having the community rehab. We'll get their feedback to say what they feel from the service and how because they're the best. Those end users are the best people to say. Would they rather be in an inpatient facility, or would they rather have their rehabilitation out in the community, in their homes? You can see the logic to that, but actually that richness of feedback is what we were going to do. We'll bring in and bring back to committee if we run the consultation as of January, and that will help form the decision going forward. Because clearly, if they feedback to actually no, then we'll take it's not a done deal. We really need to understand what they say, and they're the end users. They'll be the best place to say kind of how they find both the old model and the new model, and help shape the future provision as we go forward.
Andy, you wanted to come in?
Yeah, I just wanted to comment on the reference to the national investment of circa 2.3 billion and will we be making any bids. So I'll just remind the committee who were around what seems like a lifetime ago, but I think it was probably around 2019, that Lincolnshire was one of only 12 systems that were invited to join the first wave of what we call the transformation programme. And over that following year, we attracted somewhere in the region of, 2.4 million, I think, for the first wave of transformation. And then over the course of the year, for many other projects, the amount of money that Lincolnshire received over and above most of the rest of the country was somewhere about £11 million, I think. And what that did was it gave us, first player advantage to be able to start building all of these new services, pathways, community resilience, community assets, really reaching out into the voluntary sector. So we've taken every opportunity to bring additional money in, and we continue to do so, although the national allocations now tend to be, we're just given the money. We're told what it's got to be spent on, but we're just given it. So that process of bidding is far and few between, although the opportunities do still arise, and we do bid for money. So we try not to miss any trick on funding for Lincolnshire, and I think we've done really, really well.
Thank you, gentlemen. Thank you, Chairman.
Thank you. Before we move forward, I've got a list of 9 speakers and I'm conscious of the time. We've got 2 more substantive items to fit in before our break at 1, so I would ask that you keep your questions succinct and concise, and just bear that in mind, please. I've got Councillor Allen next.
Thank you, Chairman. I'll try and be precise. I thought it was a very good report, and it's very clear what was being asked of this committee, and I'll come back to that very, very shortly. And whilst I'm very keen to support my colleagues from Grantham in anything to do with Grantham and health service delivery, it does seem to me that this particular place in Grantham, Ashley House, is really bringing people from all over the county into Grantham rather than servicing a specific need for residents of Grantham. And it does strike me that the COVID situation has allowed us to pilot delivery of health service, mental health service delivery in Lincolnshire in a better way, using the resources that were previously dedicated to Ashley House. So I'm very happy in terms of supporting. I've got 2 questions though, but I would be very happy in terms of supporting the option that's been put forward, which is to effectively continue with what the situation that's taken place during COVID and since COVID, in terms of moving resources into a wider delivery of home-based mental health support across the county as a whole. And I would also support the supposition that's being made that whilst it's important, it is not a significant health change in terms of some of the ones that we have to deal with, and it could be a more targeted consultation as well. Because I think one thing that we do and we have to do is spend an awful lot of time on consultation, but it must take resources away from frontline delivery almost, and that's something that we can't allow for at the moment. The two questions I've got is, will the in-house delivery be supported on a 24/7 basis? Because presumably that's what happens in Ashley House. So there is support there when people need it, even if it is out of hours. And can I have confirmation that there is going to be the financial resources to continue to deliver the model in the way that has been done, and it's not dependent in any way in terms of selling Ashley House or dealing with the maintenance costs of that. It can be funded with the resources that actually do exist, and maybe even a surplus.
If I may, I'll address the first question, then maybe hand over to Andy about the ongoing funding arrangements. So the answer to the question is the community rehab service won't be 24-hour, and I think that's the difference and differential between the inpatient provision and community provision in this scenario. So it will be extended hours, 8 till 8, potentially up till 10, but I think this is part of the engagement consultation work that we need to do, is to test that out with people about what's sufficient to meet their needs, but it will be across 7 days a week. And I suppose that there's a tipping point at which somebody needs that 24-hour care. That's the point at which would indicate they need to be in an inpatient environment. And so, but absolutely, these are some of the questions that we can test out through the engagement process.
Thank you, and I'll pick up the second question about funding. I'm sure the paper sets out the historical funding associated in the cost of the new model, and it works out quite nicely. The money available is there to support. I do not foresee any scenario where there would be any issues about continued funding of this service. And if anything, as more investment comes into Lincolnshire for mental health services, we would probably want to see these sort of services and this service actually expanding and becoming, having a much greater emphasis on keeping as many people at home as possible. I have no insight yet as to what would happen to the building of Ashley House, but this service is not reliant on selling off property to fund it. So I'm absolutely able to give you assurance on that point.
Thank you, Chairman. I was very content with the question, responses to the questions, particularly the one about the 24/7 provision and that being dealt with, through the Boston unit probably. Thank you.
Thank you. I've got Councillor Rice Oxley next.
Thank you, Chairman, and thank you for the report. Really interesting. Like Councillors Wootton and Wootton, I'm a district councillor in Grantham, so of course I'm particularly interested to get good outcomes for residents in the Grantham area. Appreciate what you're saying about patients at crisis point being in the acute wards. So these patients at Ashley House were certain patients who needed this particular extra step to sort of ease them back into the community. So I can see it's quite a small number of patients that would need this particular service. Transition back into independent living is absolutely key. I believe, as you do, that comprehensive mental health provision in the community, in people's own homes, is the best thing. Everybody says that. But people leaving hospital, they need to retain access not just to trained mental health nurses, but also to consultant level when they need that. Transition from acute mental crisis isn't, as you know, it's not a straight line. So would patients be more likely to stay for longer in acute wards to begin with, like the ones we have here in Lincoln? Would those wards need to be flexible, able to maybe take people back in if they needed to go back in for a short period of time, if they had a dip or whatever? Would the acute wards have the capacity to facilitate that? Thank you.
That's probably a question for myself. So the answer is no, I suppose, to those bits. I'm absolutely confident. Something that's very close to my heart I've been working closely on reducing the number of people in acute out of area placements from Lincolnshire, making sure that we've got the right level of acute care locally. That's something that I monitor daily because of the blood, sweat and tears that we went through to get to the position of where we are now, which is a much better position than many places around the country in terms of the appropriate acute capacity locally. And so every decision we make is carefully considered to make sure it doesn't affect that pathway, I say, because of the challenges we've been through to get to where we are today. Can we have absolute assurance that the pathway we're putting in here through these patients in Ashley House won't affect the acute length of stay, it won't affect acute readmission rates, and it won't affect the length of stay within those wards. It's a different set of needs. If we found that in any way that happened, we would reevaluate the model and try to understand why that was, because we know we need to protect that acute capacity. And one of your questions begin around the consultant input. We're really keen that we've got a consultant psychiatrist involvement as part of the working model, so they're part of the multidisciplinary team. It's a range of professionals that does include consultant psychiatrists, so there is that continuity beyond discharge from an inpatient setting into the community who can keep that level of oversight going. So it's something that's quite close to my heart, and I'm very keen that we don't impact negatively on other pathways in the system.
Thank you. I've got Councillor Smith.
Thank you, Chair. Before I begin my line of questioning, there's actually a question Councillor Linda Wootton raised that wasn't addressed, which is around medication, because I just did a quick Google while other speakers were speaking. The Mental Health Act was last updated in 2007 and then the white paper, but that hasn't progressed. And my understanding is unless you are in a facility of description, you cannot mandate somebody who is on medication for depression to take it. Unless that's changed, and it may have changed, but I don't believe it has. I'd very much welcome comments on that after I finish my line of questioning, Chairman. This report, and I'll be honest, Chairman, it follows on actually from our working group on suicide, actually concerns me quite substantially, especially when you read subsection 2, and particularly, and I quote, and also enable patients who are currently in high dependency rehabilitation placements to be cared for in less restrictive settings, including some people who are currently placed in locked rehabilitation units outside of Lincolnshire, end quote. Chairman, for some people who suffer with mental health, and to quote the report, a restrictive setting can, in some instances, even if it's a minor restrictive or hospitalised setting, be the best place for that patient in the short term to stabilise them before luring them gradually down the chain of support. What this report, to my mind, Chairman, is seeking to do is put a vast swathe of support in the community rather than in a more intense fixed setting. And whilst those who are at the lower end of the support chain may be able to use this option, I believe that some who would benefit from the current facility would not be able to use this. Secondly, Chairman, as the report states and goes on to allude, LPFT's bed stock for this tier of care is already quite low, I would say very low. Having in the past tried to assist people with mental health in Lincolnshire in medium to low risk of suicide with or without issues around, say, addiction and needing support for both, it was virtually impossible to get that said person any form of treatment in a facility. You were looking at out of county by quite some considerable distance. So I would urge caution on this, and my personal view on this is I think it's a mistake. It's quite convenient that travel is used, Chairman, because we are often sat here and told on many other occasions patients are willing to travel for better care. Now this seems to be flipped when it seems to suit, to put it bluntly, Chairman. My views may seem old-fashioned in this regard, considering my age, Chairman, but I hold them because I've got lived experience of trying to assist people with mental health. And when you get to care in the community, everything, to be blunt, in my experience, falls away and they deteriorate quite markedly. And I don't think this will address that. And I think actually we could be putting our foot in it when actually we need to keep the facilities like this that we've got, because it's a more gradualised step of an in-treatment facility rather than you're a medium tier and you come down to in the community. That step, for some people can do that, and you know, more power to them and well done for doing it, but for some people that step is too much, and I think that it would be a mistake to close such a facility, whether it be in Grantham, wherever it may be, but especially given, as Councillor Wootton and Wootton have already alluded to, the previous issues around things of being temporarily closed and then haven't been. I take Councillor Anna's point of view that I wouldn't recommend that it necessarily goes through NHS England consultation framework for the reasons outlaid, but I have serious concerns around this, and I don't think that this new model will actually work how it's intended to.
Just before I bring in our presenters, what we're being asked today is that, would we like to see a full consultation, or do we want to see a localised consultation? We're not being asked about the service per se today, and we will have a paper coming back to us to discuss whichever way they go, whichever route. So just ensuring that we do hone in on that, but I will hand over to our presenters just to answer some of the questions that Councillor Smith has alluded to.
Thank you, Chair, and thank you, Councillor. So just to pick up your specific points there, to give you some reassurances around that, is that absolutely inpatient services are a vital part of the mental health care pathway. We couldn't operate without them, and some people need them, and that's the most appropriate treatment that's available to meet that person's needs. And that I'm a big advocate of appropriate inpatient care. It's making sure that we're just not putting people in hospital necessarily, and if there's a better way of doing that in a safe way that can meet people's needs in a more effective way, then we absolutely should consider it. And that's where this proposal and this new model of working is coming from. I maybe haven't described the pathway as well as I could do in terms of the in the paper, because the current pathway is there are two levels of rehab, high and low dependency, and so there's at the moment we've got high dependency, some of which is provided in Lincolnshire, some of which is provided outside Lincolnshire, and we've got low dependency, which Ashley House is providing, and that's all. This new model is introducing high, low, and then adding this new intensive community rehab service on the end. So it's an addition to the existing pathway. We're not reducing any high density beds. That bed stock is still available. We will use out of area if we have to. We don't like to, but nobody who has those needs it won't be that their needs are unmet. So it is an addition to the pathway, not taking something away. In terms of your question around the Mental Health Act, is the Mental Health Act is only applicable obviously in certain circumstances because it's a significant deprivation of liberty. In those circumstances, the use of medication can be prescribed in a different way and be mandated, I think, as you described. But that's only relevant to people under Mental Health Act, and nobody in this service, in the community service, will be under the Mental Health Act. If somebody needed to be detained under the Mental Health Act, then they would absolutely be in an appropriate inpatient setting. And there's all the evidence had to date since the model that we've been piloting since Ashley House temporary closed suggests that anybody needing admission under the Mental Health Act that meets the needs of a rehabilitation need will absolutely get a bed. We know that's been available to them. So absolutely confident that those who've got the Mental Health Act need will be in a bed. We're adding to the pathway. I think the things that this committee's heard in the past about pressure on beds have not been around the rehab pathway. It's been about that acute care need, and we have had problems in the past in people travelling really long distances to access care and support. But I'm pleased to report that we're on top of that now, have been for some time, and as of today we have 0 inappropriately placed acute patients. So those with acute mental health need, we're at 0 and have been for a while. So we're now on top of that, but as I say, that's a slightly different pathway. I hope that helps.
Thank you, Chairman. Thank you for the clarification. The only thing I would say very briefly is, having tried to assist people in a rehab pathway, whether it be for mental health and addiction or both, when I used to be involved in a CIC, it is nigh on impossible to get them the help they need for that in Lincolnshire, whether that be moderate or low, in an inpatient facility. And actually that's what, in my experience, that's what they need, those individuals needed. Okay, not all do, but I would take... Issue is the wrong word, but I have different experience to you on the level of pressure, is all I would say.
Before you respond, I would just like to build upon that from what Councillor Smith's saying. I mean, we are seeing higher cases of mental health arising since the pandemic. Are you confident that this model is actually going to be future-proofed and we will not see a need for those beds in the future? You know, it's okay saying we don't need them today, but what in 2 years, 3 years, 4 years?
So I suppose there's a bit of a crystal ball in there in terms of what will happen longer term in terms of demand for mental health service in Lincolnshire. But what we're seeing is that the demand for rehab isn't increasing. What we're seeing in terms of demand, it's often at people to kind of low low-level mental well-being and mental complexity, but also at that acute end, so crisis support. And so we're doing a lot of work around that area to bolster crisis services, as Andy referenced earlier. The Community Mental Health Transformation Programme, we're building in a number of crisis cafes. We want one in every town and every small village, if we could, where there's support in local communities. And then we're reviewing the capacity of our crisis services to make sure that that's done in the right way. I think in the last item, there was reference to the new mental health assessment centre we've just introduced. It's providing a real opportunity for emergency services and people to connect in. So we are really bolstering that crisis support. And I'm confident at this moment in time we've got the right number of acute mental health beds in Lincolnshire, so we're confident that we've got the right capacity. So we have got that where the demand is hitting, we've got the right capacity from an inpatient, and or we're building the right capacity from crisis. And I say from a rehab perspective, we're not seeing that filtering through now. If in 3, 5, 10 years from now it does, then obviously we'd have to review our models. But at the moment, the indication is not. And the other thing I would say is that by allowing all the resources that previously allocated to Ashley House to be moved into the community rehab team, we'll be expanding that team even further, so that we'll be building additional capacity so that more people can be supported. So I'll give us a bit of a headroom and a bit of a cushion to be able to absorb any variations in demand over the next kind of few years.
Okay, thank you. I've got Councillor Parker next.
Thank you. Just from the outset, agree and support the proposal as it stands for the consultation. I think one of the elements in the debate so far that we haven't quite addressed is that this is about empowerment, and if you empower people to be cared at home and in their community, you don't just empower that individual, but you empower their networks, their family, their friends, the parents, siblings, whoever, who are helping support. And you can't do that if you've got somebody in an inpatient situation. And I feel that really, really, really passionately. And I would ask that when you come back, that we try and have a look at that and unpick, not just about what strength you harness from your staff, which you've spoken really well about and really passionately about, but how they can then interface with families. Because I think that's a crucial element of this that we haven't quite got the grasp of as a committee, and yet I think is really important to this model moving forward. I don't see this as centralisation. I see this, as I say, as an empowerment model for individuals and for the community. And the whole point about travel is that we do not want the travel to these services. We want people at home. It is the best place. I absolutely know it is the best place for people who are dealing with any mental health condition, is with their families, with their loved ones, with their communities. So I hope we don't lose track of that and think that we're talking about something different. There's we can do this. We can do this.
Thank you. I've got Councillor Loughagan next.
Thank you, Chair. Part of my question is to echo what Councillor Parkin said about support for families, partners and carers if people are going to be in the community. But also I don't get a picture from what you said about what this community care will provide, how much of it is face-to-face, how much support for families is face-to-face, how much of it is somebody on the end of a telephone, and what happens if somebody does stop taking their medication, has a sharp deterioration, what's the speed of response under those circumstances? Thank you.
Thank you. I'm happy to pick those up as well. I think support for families is integral to the model, and I think as Pete's alluded to earlier, we can stress test that through the engagement and consultation process. It's a real opportunity to engage with families to understand what support is being provided and whether that's adequate or not. But the staffing ratios in the team will allow the staff to be out face to face. The idea is this is care and support provided in people's homes physically and out in communities. So yes, we might supplement that if it's suitable to the service users to have telephone contact and Teams support. But the vast majority of the support is direct physical face-to-face contact out in homes and communities. So just to assure you on that. And as part of that, we know that the strengths-based model around building capacity in families and communities is about working with families and to make sure that they're a part of the care network, and that's going to be part of the success for people in terms of fulfilling their true life potential is engaging families, friends, and support networks around them. So that's integral part of the model, and we've steered away from just a traditional nurses and doctors, are they're absolutely core to the service, to say what other professions can we bring here, occupational type roles, housing support, and other things that we might be able to bring in to really bolster that kind of holistic approach to people's needs. So I think hopefully that's answered your question, but it's absolutely integral that it's out in the community, in people's homes with them and their families.
Okay, thank you. I've got Councillor Overton.
Thank you very much, Chairman. I think to go out to consultation after the unit has closed is very undermining to the whole process, especially when the staff have been redeployed. And I think, therefore, I just think the whole process is flawed, and we have seen it before, and it is very disappointing to see it again. On the issue itself, I think the point about people are better at home, the problem is that's only if you can cope. And those who have first-hand experience of these kind of issues, it can get just so difficult that you cannot cope and you cannot be sure that you can keep your loved ones safe. And that's why these acute units are so important. Then there's the issue of this one, Ashley House, which is the step down, I would call it, rather like we had step downs in care. People coming out of hospital, we have a step down place, which means that they get an increased level of care. And particularly I liked Councillor Rice-Oxley's description of the up and down. You know, this is not a straight line, absolutely. And to be able to have that safety net on hand. And that's why those 52 people were referred to that unit, because it was the right place for them. They were not safe enough to go home yet. And yes, we want support at home, but you had that step down. I think if it's closed, I think it will have an adverse knock-on on the acute support, because that's what we see in hospital. You take away that step down, then more people want to stay longer in hospital because they do not feel safe yet going home. So I actually think this is really important to keep a step-down unit as you have here. Just a question, if I might, on the practicalities. There was one in Grayleys, which I visited, and then it seemed to close. Is that part of this one? Or just if you wouldn't mind just explaining that. I know there's two at Ashley's, but there was one, two at Grayleys. There was one round the back, and then it closed. Is that a satellite of this one? Is there a connection? But I understood that was also for low dependency mental health. So is this one in isolation, or is it connected? Then I think lastly, just to say that there is an efficiency in having people living together who need a high level of care, in that the staffing can be organised. When you've got staffing driving all over the countryside to get to people, it's important they do, obviously, but it would be more efficient if they were all in one place. And so I think for that step-down care, it's actually probably more efficient to provide the service for those people who need it, which isn't very many, but those are important. And actually that step-down care is important and efficient, and it has a very good performance. So why close it? Thank you.
Yeah, thank you. Great questions. And I think, a reference to what I mentioned earlier about inpatient and community service, both are necessary. So, and we need to have the right proportion of both. And certainly, those 52 patients that are admitted over the last few years, did need that, require that service. We've deemed that was the best thing for them. But in the context of the services that were available at the time, and what we've found is now we've introduced community rehab, that offer of support. There are alternative offers of support that can meet those needs in a different way, and that seems, that's been proving quite successful. And obviously we need to stress test that through consultation, but everything we're seeing here at the moment is suggesting that that is working effectively. I think just important just to point as well that as the step down that we described there is still in place. So we've got Maple Lodge at Boston, so people who do need that level of support, it's still there. We just say we don't need as much of it now we've got the community rehab team in place.
Okay, thank you. Okay, Councillor Dr. Thompson.
Thank you, Chairman. Thank you for the report. I may have missed, but could you give an indication of the length of patient stay in Ashley House before it temporarily closed, or the current Maple Lodge equivalent, please? Thank you.
I'm happy to come in on questions. I see Andy's got his hand up as well, but just on that, the average length of stay is usually around, it varies from patient to patient, but between 6 and 18 months, just depending on the nature. And often that will depend on how long somebody's been in the system. If somebody's been in, long-term care for a number of years, it will take longer to do that rehabilitation, where if someone's had a shorter episode of care, then it'll be slightly different, but between 6 and 18 months, I would say.
Thank you. And finally, I've got Councillor Chalmers.
Thank you. My question, I've got a few questions really. Ashley House, did it completely fail? Because it was obviously built for a reason. And if you've got patients that are in there for 18 months, that's a phenomenal length of time to just kick that out and either say you remain in hospital or you're discharged to a home environment. I'd want to see a consultation and a very in-depth one before any decisions are based, because I feel that these are important services and we should be increasing the overall mental health services that we have, not decreasing them, because we've got an increase in mental health issues. I want to know of the patients that stayed at Ashley House, what percentage of them, and how did those percentages compare to other rehabilitation? So did every single one of those 52 people come out, rehabilitate nicely into the community and go on to live a healthy, normal life and kind of disappear from the system? The outcome of that would be 100% success rate versus, 52 of them all ended up either back in hospital or it didn't work for them. We have to see the results before we can look at any kind of decision as to whether it worked, didn't work, or whether we want to close it. Did it fail? Did it succeed? They're two massive questions for me.
I'm happy to pick up that question. I know Andy and Pete have got their hands up. So if I just to pick up that question specifically, Ashley House wasn't a failing unit. It was a really effective unit. There's issues in terms of the environment. It's more of a kind of home environment than a hospital environment. So which lends itself potentially to alternative use in the future. But obviously we need to explore where things in turn. What I would say is that it wasn't, it was a successful unit, it's operating really well. This is not about a failing unit, we need to do something differently. Is that assessed circumstances arose that led us to trying out a different model of care that's in line with the national strategy, and that model seems to be working really effectively. And as I stand here today, there isn't the need for those beds. That if we opened it today, there wouldn't be patients that needed to be admitted into those beds, because we can adequately care for the population needs through the community rehab team or through Maple Lodge. So that's I suppose why we've led to the proposal. Is under the circumstances we reverted back, opened up the unit, but it's given us pause for thought to say, actually, is that the right thing to do for people, to put people back in hospital when we're successfully treating them in the community? Hence we're suggesting that we need to consult and understand what is the right model of care going forward. But I see Andy and Pete want to come in as well.
Yeah, sorry, if I could go first. I just wanted to respond to the comments about how efficient it is to keep people with a condition all in one place. Yeah, of course it is, but it's not the right thing to do if those people can live in the community. And, I recall my father was a nurse, a learning disabilities nurse, and worked in a very large institution, very large hospital, where it was felt that that was the best place for people to be because it was efficient and that they could be controlled and managed much easier. And I remember as a child, actually, I used to go and visit him at work. It's probably not appropriate, but I did, seeing these dormitories full of people with physical health needs, learning disabilities, autism, psychiatric issues. And when the decision was made to close that hospital to allow people to go and live in bungalows in the community, there was significant opposition. But that's not a place I think we would ever want to go back to. So I understand the rationale about effectiveness and critical mass, but it's not a comfortable place for me to be in. And we should do all we can to provide bespoke wraparound care for individuals in their own homes and in their own communities. Thank you.
Just to clarify, if I may, just to clarify, it wasn't suggesting what you've just said. What we're talking about is whether this step-down unit should be available for people who are going to struggle at home. Thank you.
Thank you. And it was Councillor Chalmers that was obviously the last person asking the question, so I would prefer it if it's not someone jumps in and asks, but thank you.
Thank you. Yeah, mine was all about the results of Ashley House and how those patients have now got on in life. That's what I need to know before we decide to close or leave this facility open.
Pete, I think you're still waiting to come in.
Yeah, and it does relate to that question. We're not here today to propose for it to shut. We're here today to propose a consultation. Well, to get your decision if it's substantive service change, and if you think it isn't, but clearly we want to consult locally with the service users. They're the best people to tell us. We'll all have experience of healthcare across the piece, both that I see from my role, but also from my loved ones who go through, and myself who access healthcare. But this is about the nature of this service is about speaking to the patients who have gone through it. There's key stakeholders involved and their families, and getting their feedback from it. That's what we're here to do. So can we consult? Are you supportive of that approach, and can we get the enrichment? When we come back to you, if we go for that process, we'll have the feedback we had from those patient groups and their families to kind of enhance any forward decision. But this is it's an enhancement to a service. So there's still an inpatient rehabilitation facility at Boston, because it's not a service that is placed on allowing just a local population to access it. As the numbers show, people across Lincolnshire access this service, and they will continue to do that. So you'll see people on the East Coast access it, even though there's a facility in Boston. So it's not a geographical piece. That service remains, but actually getting people, as Andy said, who can live their lives and be supported to live their lives in the community is what is the direction of travel. But actually, let's see what they say, and let's see what they tell us about the service, and then we can make a decision supported and informed by their viewpoints, really.
I think, if I may, before I ask a question, we had a very similar situation with the acute services review where, whether we decided to go out and, this is a similar sort of situation in terms of if we go out to a full public consultation, that we potentially could end up with this service remaining closed anyway for a period of time while it goes out to a massive full consultation. And so in that period of time, we're actually losing two services potentially. And I think that's something that also needs to remain in the committee's mind, whereas targeted, I think, in some areas, if we involve ourselves with it, might be the right option. Okay, I have one question, if I may, and that is the engagement with patients to date on the bullet points on page 34 provide a range of feedback, some of which relates to the existing community rehabilitation service. How are these being addressed, please?
Sorry, is that in relation to the positive feedback around the current community rehabilitation service? Sorry, to clarify the question, if you may.
Yeah, that's correct.
Yeah, so I mean, obviously that gets fed into the service. So from a service perspective, we've got staff and managers from the service actively engaged in those engagement processes. So they're hearing and receiving the feedback, and we can use that to adapt the model. We've had an opportunity through this process that we're presenting today to refresh the model, look at the staffing profile, and make sure that we've fed that feedback into that process, so we've got the right level of service. So what we're in the next phase of this will to really enhance the service model with based on that feedback. And what we try to do these days, we've got a very good relationship with the ICB as our commissioners, and we work together. There's not so much rigidity there might have been in the past in terms of commissioning specifications and formulas and then process targets. It's much more about adapting to the needs of the populations that changes over time. So we've got a really good model. It's stress tested regularly. We would continue that feedback now and in the future, to make sure that we've got opportunities to learn and adapt as we go along. So a long-winded way of saying that feedback has been provided directly into the services, and we adapt the model on that basis.
Okay, thank you. In which case, I'm going to make a proposal from the chair, and my proposal is that we note the report on the development of the Lincolnshire Partnership NHS Foundation Trust for Ashley House Services in 2019. That we now provide the guidance on whether we feel this is a substantial service change or not, and therefore the level of consultation it is felt required from the options below. I actually propose that we don't consider it to be a substantial service change, thereby enabling a locally led targeted consultation process with patients. However, that we also take part as a committee in that targeted engagement so that we can ensure that the views are heard, and obviously our views are heard also. Do I have a seconder? Thank you, Councillor Allen. So that's been proposed and seconded. All those in favour, please show. Thank you. Against? Abstentions? Thank you. That's carried. Thank you very much to our presenters.
Thank you very much.
We'll now move on to agenda item 6, replacement of the Lincolnshire Acute Adult Mental Health Inpatients Bed. This item was circulated as part of the agenda pack on pages 47 to 57, and I'd like to welcome our presenters, Chris Higgins, Director of Operations, Mark Platt, Director of Finance and Information. I'll hand over to you just to quickly run over. Thank you.
Excellent, thank you very much. So if it's okay, I'll start and hand over to Chris. So good morning, everyone. I'm Mark Platt, I'm the Director of Finance and Information for LPFT, and I am the exec sponsor for this project. So I'm here today to kind of talk through the focus of the project and the content of the paper. So a bit of background around this, and it kind of follows on from the previous discussion, really. You know, when a patient needs an acute mental health support period of time, we've got to get that environment right. We've got to make sure that it's really conducive to the best patient care that we can provide. So this business case really kind of presents to the committee how we're proposing to do that, both in Lincoln and in Boston. So obviously it's part of a national drive to eradicate dormitory accommodation. So we have currently 3 wards left in Lincolnshire. So we have 2 wards in Lincoln itself and 1 ward over in Boston that are left as dormitory wards. But all of those wards are a minimum of 4 to 5 bed bays and can be really quite noisy, disruptive environments, which isn't great for patient dignity, care and recovery. So it's really important that, as you know, when we've got inpatients in there that are possibly in stays for 30 days up to a month over a bit, we've got to make sure that they feel safe, secure and in the right environment and have really strong, decent access to open space to help them support rehabilitation to get back into the community at the end of the pathway, hopefully. A quick update on the Lincoln scheme. So this scheme was the first one to progress because the trust had access to the right land in the right location to continue the build. So as the project's continued, we have found some challenges around sourcing and cost of materials and quite a few economic factors around there. But overall, the project is going well, and we are due to open both replacement wards in April 2023 on what is currently the Peach Hodgkinson Centre site at Lincoln County Hospital. So a lot of learning through that development of the business case and the building process that we can take on and move forward to really make sure that our proposal for Boston is the best it can be. Appendix A within page 55 of the report gives some illustrations of the patient environment and what the new unit will look like. In terms of the Boston unit, so obviously this one hasn't quite progressed at the same pace because ultimately our current ward is placed on a really busy, congested acute site at Pilgrim Hospital. So our access to land and wide open space is really quite limited, really. So it's really important, as I say, to get the right proposal in there where we can meet the best criteria that we can. So our project team, we've reviewed a number of options around various building locations and build designs to make sure that this proposal that's included within the paper today is the best proposal we can put forward. And that proposal is ultimately to actually move the site, to move the ward. So the proposal is to move it 3 miles south within the Boston area to the Norton Lee site. This is an area of land that the trust has owned for a number of years, but has been derelict since services closed there around 15 years ago. So ultimately, it's going to be a new site build, a brand new building, It's going to be a lot more accessible to patients and visitors to the site, as the table on page 51 can illustrate. It's on bus routes and the accessibility is there. So hopefully the committee will agree the proposal is really going to benefit the local community. However, for the purpose of the paper today, it was about making sure that the committee were aware of the level of engagement that we've gone through as part of the development, and agree that we've pitched it right and it's sufficient to meet the trust needs to open the build and move forward. So I just wanted to give a bit of background around the level of engagement we've had so far and what the next steps are and how we can move forward. So throughout all three projects, we've had really strong service user engagement where we've included patients, carers, staff reference groups. We've developed a building it together team, and this team have really been at the hub of the design. We've really got to make sure that both the units, the public, the social areas, the rooms, the outside space is really right. A lot of wide open space and a lot of access to light. A lot of learning from that, certainly around from the patient experience and how they feel the environment will help them ultimately get better and move on. So we've included those for all the schemes really. So that's been a real core of the whole project, regardless of the Lincoln and Boston location. In terms of the Boston location, because it is a move to a new site, we've not only worked locally with neighbours around the adjacence to the site and really kind of kept them informed and made sure that they've been aware of key actions on site. So the site's now been cleared and it's a much more safer environment, and kind of work through them. But it's really important to get their views around the use of the site and what impact that might have. So we've worked closely with local neighbours. We're also engaging with local organisations, healthcare providers and community groups to make sure that the future of that site can be the best it can be and almost be a hub for mental health and community-based care moving forward. And within the next month, we're also holding 2 public engagement exercises. So I'd welcome anyone to come down and meet myself and Chris and the team at those engagement sites. We've got some really good illustrations, plans of the drawing, and we can really bring the development to life. So really encourage people to attend that. It'll be a good session and be really good to meet everyone. So as part of that, the proposed build is due to be completed by June 2025. So we are at the early stages of the business case development, and I am next week, Chris and I are presenting the business case, the outline business case for funding approval. So enable us to move forward on that. So we'll keep the committee up to date on progress on that. But that gives us time to continue that high level of engagement and make sure we really get that design right. So I'm just going to hand back over to Chris to talk through some of the clinical benefits of the project before I just draw to an end and talk through the recommendations in the report. Thanks, Chris.
Thank you, Mark. So, I mean, as somebody who's worked on Ward 12 and is responsible for management of Ward 12 and lives in Boston, I'm quite excited by this project. I think when we first opened Ward 12, there were, state-of-the-art inpatient environments for people with acute mental illness, and you fast forward 20 years and they're quickly outdated, and things you didn't see at the time now seem obvious, like when you're feeling particularly probably at your most vulnerable and maybe paranoid, worried. We put people in shared dormitories where there's only a curtain between you and the people next to you, which just seems odd, doesn't it, in terms of recovery? And certainly at a national level, that's been recognised, and locally that's not conducive for recovery. And what we do is give people safe spaces to be cared and treated for in, and we need to do something different. So this new development really offers that. It's a great opportunity to put the right environment, both from a sleeping arrangements, but also those social spaces that Mark's referred to there, whether it's access to toilets, whether it's access to living spaces, access to outside spaces. It's a massive improvement on what we've got. So beyond the dormitory issue, which we know is the driver behind this, the other problems that we've got in terms of challenge we've got with our current environments at Ward 12 is it's on the first floor. So that means that anybody wants to go outside. Sometimes people are detained under the Mental Health Act, or quite often they can be on those units. So they need to be escorted out. So that is a draw on staffing time, and sometimes it can't be facilitated in the moment. People haven't got that free access to outside space and fresh air that we would want to, and we have to plan that and facilitate that with extra staffing to enable it to happen. Whereas the new unit's going to solve both those problems. Private ensuite bedrooms, great living spaces, and then free access to outside space, which is what everybody should have, particularly when you're at your most vulnerable. So really great opportunity to do something brilliant for the people of Lincolnshire. I've walked around the buildings at Lincoln in terms of as they've been under construction. You can feel the space and the airiness of it, and it's just a really nice and natural space to be in, considering you're in an acute mental health inpatient unit. So real positive opportunity. And then I think what Mark said there is that the size and scale of the site offers opportunities to do something different. You know, there's a range of options that we might want to look at about consolidating services, developing new services, working with partners in the community to do alternative things on site. So there's an absolute benefit from the urgent, you know, the immediate project, but there are other benefits that the project might bring down the line as we build infrastructure on that site. So yeah, I'll stop there and just open up to questions. And yeah, thank you.
Okay, thank you for that. Councillor Allen.
Thank you, Chairman. I'll keep it brief. I can't see that this committee can do anything but support this proposal because it will do exactly what's been said by the presenters. It's very good to see that the budgets the budget line in Lincolnshire allows £37 million to be spent on this, and it will hopefully bring significant improvements. I should just say that hopefully it will be rolled out across the hospitals as a whole, because it would be nice to see that privacy, dignity and recovery applies to all patients in the hospitals. And certainly my wife would have appreciated it, I think, having a stay of 2 weeks last year where she hardly slept at all during her stay in the hospital dormitory ward because of the mix of patients with dementia and normal patients that existed there. She just did not have a chance to recover or to even sleep. Thank you. I'm not necessarily looking for a response, apart from maybe a positive one.
Thank you. I've got Councillor Smith.
Thank you, Chairman. I'll be equally brief. Could we be advised what an S140 assessment bed is? And as Councillor Ann's already said, this is a brilliant proposal, and all we can do, I think, is support this, and it's something I hope that is rolled out across our other hospital sites when financially available. And the sooner that we have more facilities like that, the better it will be for people who need that acute support, because as Councillor Allen said, the last thing, if you're in that state, you want is to be in a dormitory where actually you have no privacy and all there is between you and somebody else is a curtain, because you are probably paranoid, because you're paranoid anyway if you're in an environment you aren't overly comfortable with and you're around people you don't know. But if you're suffering with mental health, that probably escalates about tenfold. So no, this is brilliant.
Thank you.
If I may, Councillor, just to suggest, in terms of the Section 140 bed, it's a specific bed that's kept free for urgent admissions. So there'll be 18 beds on the ward that will be occupied most of the time, but we'll make sure that one bed, what we call the Section 140 bed, is just described. It's the description of the bed that's kept free as often as possible, so that if anybody needs an urgent admission, there's always a bed available. We get them into that bed, assess them, and then move them into one of the other beds in the ward. It's just to make sure we've got good flow and bed availability.
Thank you very much. Councillor Chalmers.
Thank you. This looks absolutely fabulous. I have one question. Is it kind of behind the station pub? I'm just trying to find it on the map and relate it to my brain, but I'm liking the fact that it's got outdoors, it's modern, and it's got breakout space and, you know, mirroring everybody else, but brilliant, all behind it. Thank you.
Yeah, just to confirm the question there, yeah, is it the railway pub?
Yeah, that's the one,
yeah,
railway station.
Near the ATF garage, yeah.
Thank you. I've got no further speakers. I've just got one question, if I may. And do you know when the outcome of the bid for additional funding from NHS England will be known, and what happens if the additional funding is not forthcoming?
Yeah, so I'll pick that one up, Chris. Thanks. So as mentioned, Chris and I are presenting to the national team on Monday. So this is part of the outline business case approval. We have already passed 2 key gateways to get to this point. So whilst obviously nothing's guaranteed at the minute, I am positive it's going to be a good discussion on Monday. So we'll feed back from that. If funding isn't available, and we have had these discussions as part of the regional and national teams around what we can do. Ultimately, if funding isn't available, we can continue to provide the services in their current state. But obviously, we all appreciate, and some great examples from committee members there in terms of they're not the best environment, but they are an environment that we can deliver safe and effective care in. So this is an enhancement rather than necessarily meeting a missing need. So, but I'm pushing out for Monday, and I will definitely keep the committee up to date on progress. So thanks for the question.
Thank you, in which case I'm going to make a proposal that we welcome the outline proposals for the Norton Lee development as detailed in the report, and to support the plans for engagement as set out in the report as sufficient to meet the NHS's duty to involve patients and the public. Do I have a seconder for that proposal? Councillor Linda Wotton. And then all those in favour, please show. Thank you, that's supported unanimously. In which case, thank you very much for your attendance, and we'll move on to the next item, agenda item 7. Lakeside Medical Practice, Stamford. This item was circulated as part of the agenda pack on pages 59 to 71, and I'd like to welcome our presenters, Sarah Jane Mills, Director for Primary Care and Community and Social Value, and Nick Blake, Acting Programme Director, Integrated Primary Care and Communities. As the report is read, if you just want to quickly go through, and then we'll take questions at the end of this. Okay, thank you.
Thank you. Yeah, I'm going to actually ask Nick if he'd just provide a quick overview of the current, and then we'll take any questions.
Yep, thank you. So I'll take it that people have had a chance to look at the report, so I won't go through that line by line, but just to give the committee a brief update. We've been going in, and by we I mean the ICB Quality and Primary Care team, working with the practice to review their delivery of their action plan, following on from recent CQC inspections. We've been going in on at least a monthly basis, but more likely fortnightly. I think in summary, the team are reassured that good progress is being made by the practice in terms of addressing some of the issues highlighted through the CQC reports. We've also had a clinical pharmacist from the ICB go in and look at the dispensary. Again, people will see in the report there have been issues, CQC raised issues around management of the dispensary. And I'm pleased to say our clinical pharmacist has reported, again, those issues have been addressed, and he was reassured by the management of the dispensary and the processes being followed. Again, just to flag to the committee, CQC, we've been in touch with CQC and discussed progress, and just to flag that CQC have removed their notice of proposals, which basically effectively brings practice out of special measures. So again, that was following a challenge by the practice. CQC are due to go back into the practice any time now. It's 6 months since the last inspection. Obviously, we don't have a date, and CQC will go in on an unannounced approach, but we understand that to be due very soon, and obviously we'll keep appraised of that position. I think that is probably the key points. The final thing I wanted to flag is in the report you'll see that we plan to carry out a quality review of the practice. We're just planning that at the moment. We've got some clinical capacity, independent clinical capacity to support that work. A GP who has also been a clinical advisor to the CQC will be going in and working with the practice to kind of review where they're at, identify any further quality improvements they can make, and support and advise the practice. We're planning to do that in November as per the plan. That's all kind of on track at the moment, and again we'll keep that plan under review as we go forward, but happy to take any questions.
Thank you. Councillor Long.
Thank you, Chairman. I read the report with great interest, or to try and find great interest, I think, particularly. The question I got, I mean, the lakeside medical practice may be unusual in terms of its size. It may be unusual in terms of the fact that it sounds like it's operated by a limited company. And it may well, but probably not, unusual in terms of it's got some criticism from its patients in terms of the provision of services, but I dare say that might apply to lots of practices nowadays. How many other practices in Lincolnshire have got an inadequate rating against them?
Yeah, so we have, Lakeside Stamford requires improvement at the moment, so that's just to clarify that point. We have one practice, sorry,
you know, how many other practices in Lincolnshire have the same CQC rating against them?
Yeah, we have we have 4 practices in total with requires improvement. We have one that's inadequate as well at the moment, a relatively new inspection that's been published recently.
Are we likely to get reports from those as well? Or is it one? Is this, because this seems to be an ongoing saga to a certain extent, and I'm just wondering why there's such particular attention being put to it.
If I may, Councillor Allen, because it was inadequate, and it is, I think, more often than not the case that you will find it gets such a low rating as inadequate, is why it came to the committee initially. With those that are requiring improvements, it is something that we keep a watching eye on, but we don't bring to the committee unless it declines from that particular point. As I think has been alluded to, there is only the one now, which is Hawthorne in Skegness, that's inadequate.
Right. Thank you for the information. It does seem as though their patients aren't dying particularly early and do live in a reasonable lifestyle as well. But thank you for that.
Okay, any Councillor Overton?
Thank you very much. On the section, one of the sections here, you've got the point about the closure of the practice, which you did, the St Mary's practice, but it seemed to have alienated a number of residents who feel disenfranchised. It's on page 62, top page 62. Just would like to ask what you're doing about that, and yeah, can you amend? What are you doing to correct that situation, please?
So perhaps if I start, so you're absolutely right in terms of I think there was a loss of confidence between the patients registered at Lakeside and the Lakeside practice. The focus of the team internally has been very much about addressing the issues highlighted by the CQC and rebuilding their relationship based on improvement in service delivery with their registered patients. In parallel, Lakeside as an organisation have recently appointed a new chief executive, and Nick and I pounced on her within 2 weeks of her arrival into post to actually discuss the history and particularly the issues around St Mary's and the impact that had had both on the public confidence and the confidence of what was the CCG and now the ICB, and are working with her to make sure that we have got a greater confidence in their corporate management of the organisation, and making sure that we don't find ourselves in that situation again.
Thank
yeah,
you.
you may come back.
I've got the local member of the area has also been in contact, so I'm just to share, so excuse me if I'm sharing some of the things. But in look at the Appendix B, it talks about the half-day session following the report to review the action plan and then developing a population plan for Stamford. So just thinking, what is the population plan, and has one been developed now, and is it available to the public? Thank you.
So thank you. So the population plan is something that we're looking at not just in the Stamford area, but we would have come to talk about Spalding, and that one was one of the areas that again was highlighted. So the population plan is intended to help us consider what are the future health needs, including primary care, but not limited to primary care, of populations, particularly where you have got significant housing growth. The framework for that hasn't been finalised, and it is something that we will be doing over the next few months to understand how best to have that community conversation, to understand more broadly what the needs are within a local population. So no, it hasn't been completed in Stamford. We are currently doing the work. We will be starting in the Spalding and Stamford area because these issues have arisen both, but it will be something we do across the county, not just in the south of Lincolnshire. And yes, the outcomes of those that piece of development work will be public because it will be a public engagement event. In terms of timescale for delivery, at this point in time, it's hard for me to actually give you a specific on that.
Thank you. The next question, I'm having to ask them one by one.
I'd normally
if I
allow
may.
2. I will allow 1 more further.
Oh,
I believe that Councillor Cleaver sent 9 questions in total. They will be shared for a written response to come forward, so
Okay.
I shall allow 1 further.
That's fine. Thank you very much. Right. So I think the important point that I want to pick up is about the GP patient report, about further work being carried out to analyse the report, and if there's any time scale for that. And of course, you've got the AGM coming up, so it'd be interesting to get some things for that. Thank you.
Yes, yeah, thank you. So we've done an initial analysis of the GP patient survey. What we will be doing, and we've asked our primary care business intelligence lead to look at this, is looking at the friends and family ratings. So that's kind of a patient experience rating, and also some other metrics and other data that we have, which where patients can give feedback about the practice. So we're going to compile all of that together and then compare that with the GP patient survey just to see what's happened over the recent months. We're planning on doing that work and having that completed by the end of October.
Chairman, for your patience. You can see Councillor Cleaver is very worried about it and has gone to a lot of trouble. Thank you.
Thank you, Councillor Overton. Dean.
Thank you. I just first wanted to highlight to the committee that this Lakeside Stamford is probably the practice that we hear the most feedback about, and it is a sort of mostly negative feedback, mostly around the trying to get an appointment through the telephone. Not to say that I think it's a practice that's any worse than anywhere else, but it just happens to be that that's where we hear the most feedback, and I think that's one of the things that there does seem to be a bit of a disconnect between the patients and the practice, and I wonder if could you just sort of highlight what work's been done to kind of improve that relationship and kind of take the patients on that journey of improvement as well.
I was just going to come in on the phone first. Yes, there has been, and the practice were very aware of really long waiting times in terms of the phone. They have made significant improvements in that by reorganising their administrative team's focus at the peak times so that the phones do get answered much quicker than they were, but not quick enough, and they recognise that. In that context, there are a number of things that they've highlighted that result in patients having to contact the practice, and so therefore ringing up. One of them is requesting blood forms, which is something that is unique to the NWAFT hospital, which we're trying to work on, because that does make the phone lines very busy. So they are doing some specific work on the phone lines, but I'll let Nick talk about the wider patient conversation.
Yeah, so one of the things they are doing is they've started to produce a quarterly newsletter, so they're updating patients via the website, and I think on the October edition they are talking about telephone waiting times as well, so the average I think has gone down from 60 minutes to 37 minutes, and that's an average, and we know at peak times it's not as quick as that, so as Sarah Jane was saying, it still needs further work. What the practice are also doing is working with their PPG to understand how they can better engage with patients, and they're being supported by Healthwatch Lincolnshire around that, so Healthwatch Lincolnshire are providing them some advice and some guidance. That work's ongoing. They've had a challenging relationship with the PPG, but I think looking to take that forward in a more constructive way in future with Healthwatch Lincolnshire's support. What we'll be doing is working with them, and they've engaged a communications company to support them get messages out to patients. Our ICB communications team are going to be working with them to make sure that that's aligned with the patient communication we're putting out. We are supporting with, we have been supporting with some listening clinics, and I went along to the practice to hear from patients directly. I dropped in. It's one of the things that the PPG organise on a monthly basis to talk to them about their experience and how they access the practice. One of the interesting things that came out of that was the use of online consultation. Lakeside have a system called Doctrine, which actually all the patients I spoke to were really positive about. So one of the things we'd like to work with the practice on is making sure that for patients who want to use online routes in, that we promote that and they're aware of that, because again, it seems to be that patients have a good experience. So I don't know if hopefully that answers your question to some extent.
Yeah, can I just come back on that? The point around the sort of the work with the Healthwatch and the PPG, obviously we suggested that we would like to support that. I think unfortunately they came back and said that wasn't something that they were willing to to do.
Yeah, so in terms of, there was, it was very specific around the PPG meeting and some support to the chair to manage that meeting, which again the chair wanted to, I think, manage that independently, but I think there's other kind of support that's being put in place. So yeah, thank you.
I think just to clarify, because I think it's really important, actually the practice were really supportive of Healthwatch being there to facilitate. It was the PPG chair who declined that offer of support. Now the PPG chair is independent and obviously in his role he can choose whether or not he wants to do that. But the practice, Nick and I had direct conversation with them about them receiving some support, and they were very, very committed to doing that. So I think it's important to differentiate between the practice and the chair.
Can you just knock the microphone off, Dean? Sorry, thank you. Okay, I've just got two questions for you, and that is, what level of support will remain at Lakeside and for how long? And then finally, my second one is, when is the CQC expected to return to Lakeside?
I'll deal with the last one first, because that's the easiest. We don't know, but it's imminent, and it will be an unannounced visit. So, but we know it will be imminent. In terms of the level of support, we will be continuing to support them, particularly through the independent quality review, making sure that what comes out of that enhances the action plan that they've got, and then we've got the mechanisms in place to monitor improvement. We won't step down the level of support until we are confident that they are in a place where they're progressing. They will, because their requires improvement, we will continue to be inputting regularly, just as we do in other requires improvement areas.
Thank you. In which case I don't see any further speakers, and I will move to the proposal. I propose that we note the report from NHS Lincolnshire Integrated Care Board on Lakeside Healthcare Stamford, including the fact that the practice has made improvements and is now rated as it requires improvement by the Care Quality Commission. We support the action plan by NHS Integrated Care Board to address the remaining areas of concerns and not to seek a further report to the committee at this stage unless the improvements set out in the action plan significantly deteriorate in the service provided. Do I have a seconder for my proposal, please? Councillor Smith, thank you. All those in favour, please show. Supported unanimously. Thank you, and thank you to our presenters. That brings this part of the meeting to a close. We'll break now and back for 2 p.m. Please start. Thank you. Afternoon session. Hope you all enjoyed your lunch. We'll start with agenda item 8, the Lincoln Medical School. This item was circulated as part of the agenda pack on pages 73 to 76, and I would like to welcome our presenter via Teams, Professor Danny McLaughlin, Associate Dean of Medicine for Lincoln Medical School. And if I can hand over to you for the presentation. Thank you.
Great, thank you very much. I'm assuming that everyone can see and hear me. I've got the chat open. If someone could just say yes in the chat. Simon,
We can,
perhaps.
thank you. If you could speak up a bit, if you could, thank you. It's the speaker system is not wonderful in here.
Okay, my microphone is here, so I'll speak as loudly as I can. I'll just share my screen. Are colleagues seeing that?
Yes, thank you.
Okay, so thank you very much to the committee for asking me to come and give you an update on the Lincoln Medical School. My name is Danny McLaughlin. I'm the Associate Dean of Medicine at the University of Lincoln. And I think I last spoke to the committee in early 2020, so there's been a lot of water under the bridge since then and some updates that I think you'll be interested in. So I'm going to talk about a few different things. The aims of the partnership and reminders of the standards and the outcomes that we're being held to within Lincoln Medical School by the General Medical Council. I'm going to mention a little bit about the setting. Apologies for this rather outdated diagram here, which shows the 4 separate CCGs, so it even precedes the 1 CCG and certainly the Integrated Care Board more recently. I'll give you a bit more detail about the curriculum, because some of that's related to the sort of Lincolnshire setting and the Lincoln flavour. And I will finish off by talking about student numbers and then give you a sort of preview, if you like, of what we are planning for an independent Lincoln Medical School in due course. So the aims of the Lincoln Medical School, which I've presented every time I speak about the school, are here on this slide. Now, I'm not going to read them out loud. Everybody can obviously read them, and hopefully you can see them on screen. But what you will see throughout this is the word Lincolnshire, Lincoln and Lincolnshire writ large. So it's very much the Lincoln Medical School for Lincoln, and you should think of it as being Lincoln and Lincolnshire's medical school. We've been established to try to address some of the sort of chronic shortages in doctors being recruited to the local area, and particularly specialist shortages as they existed at that time. And we're really trying to use the medical school as a vehicle, if you like, to unlock the potential of Lincolnshire and drive innovation, improve research and industrial partnership in medical education. And it's a slow journey, but I do believe that we are making some headway in some of that. And hopefully, come 2024, when our first set of graduates actually graduate, then you should hopefully see an influx of junior doctors into Lincolnshire thereafter. Just a reminder that we are a medical school which is accredited by the General Medical Council. The General Medical Council specifies certain standards for excellence in medical education and training. So this encompasses everything from medical school through to postgraduate training, all the way up to consultant level. And we are asked to map our activities and provide reassurance to the General Medical Council in various themes. So there are 5 themes and 10 standards that we are held to, and everything we do is driven by a risk register mapped against these various standards to ensure that we're checking off everything that we need to do. We are currently a partnership between the University of Nottingham and the University of Lincoln. Our students register as University of Nottingham students, but all of their teaching takes place in Lincoln and Lincolnshire across the 5 or the 6 years of their degree. So this accreditation is held currently by the University of Nottingham, but as I've said, we would like to become independent in due course, and I can tell you a little bit more about our hoped time frame or time scale for that towards the end of the presentation. In addition, and probably more relevant, or certainly more relevant to undergraduate medical education, are the GMC's outcomes for graduates. And these are organised into 3 groups of outcomes. They used to be the other way around. We used to talk about knowledge, skills and behaviours, and in the most recent iteration of outcomes for graduates about 4 or 5 years ago now, the GMC turned that on its head quite rightly, because actually what they first specify is that medical students and doctors need to be able to demonstrate the appropriate professional values and behaviours, and without those they cannot demonstrate the professional skills that are required. And also, they cannot necessarily, if they don't have either of those first two, demonstrate any of the professional knowledge required. And we have a diagram on the right-hand side, which basically shows how across these various groups of outcomes, professional values and behaviours, professional skills and professional knowledge, there are several domains of what's called the generic professional capabilities framework that can be mapped to each of these types of outcomes. And in order to graduate a student as a doctor and to put them forward for provisional registration with the GMC and a licence to practice medicine, we have to reassure the GMC that our students are meeting all of these outcomes, 22 big level or high level outcomes and many, many more sub-outcomes within those. So it's a fair job of work and fairly highly specified as to what we need to be doing and what type of graduates we need to be able to produce. I wanted to just talk a little bit about how what we do at the University of Lincoln element of Lincoln Medical School varies compared to that at the University of Nottingham. So the students are registered as University of Nottingham medical students, and they undertake the same assessments as their peers in Nottingham. But we have some distinguishing features. The first of these, and one of the most important, is that students are studying in a much smaller cohort of students. We have 80 students in the first year of the programme. That's the controlled numbers that we receive from the Department of Health and Social Care each year, and that's in comparison to 250 or more in the first year at the University of Nottingham, or the programme based at the University of Nottingham. So we're able to give the students much more of an individualised and small cohort experience. Another main difference is that when we teach anatomy with prosected cadaveric specimens rather than allowing the students full body dissection opportunities. But that's a process which has been well recognised over the years to produce just as good anatomical knowledge as full body dissection does. And certainly our students do very well in their exams where they have anatomy as an element of a component of that assessment. We very much focus on developing a collegial culture from the start. That's helped to some extent by our small cohort. It's helped by having a relatively small group of extremely dedicated members of staff who will look after the students. And we emphasise to the students that we have a statement of values and ethos of Lincoln Medical School, which is very inclusive and ensures the students set off on the right foot. We have various initiatives to support student wellbeing, which have become incredibly important over the course of the pandemic. And our faculty, so our academic staff, some of the disciplines they're particularly strong in are in mental health and general practice, and that's perhaps a little bit different to the University of Nottingham and perhaps some other older and more established medical schools. But one of the ways in which we give the Lincolnshire flavour to the curriculum is by student-selected modules. And so we have student-selected modules which are delivered by colleagues in the University of Lincoln, other colleagues outside of the medical school. We have student-selected modules which are offered by clinicians in the local area. And we have clinicians in the clinical phases offering student-selected modules as well. So that reflects very much the interests and the research emphasis of some of those other departments within the University of Lincoln and the local trusts, including everything from mental health to public health. We have student-selected modules in things like social prescribing, global health, and addressing the needs of diverse populations, including rural and coastal populations as well, which is something that you just wouldn't see in much of the offering from the University of Nottingham Medical School. So we are being true to our word in giving the curriculum a Lincolnshire flavour. And as I've said a number of times now, when we become independent, we will be able to emphasise that even further by developing our own independent curriculum, which will still meet the requirements of the General Medical Council, but which will probably more closely align to the health needs of the local population in Lincolnshire. And local problems are very often national or regional, national, and potentially international and global problems. So students will be well prepared to make a success of their medical practice, no matter where they undertake their future training. We have students, when I last spoke to you, I think we only had students in year 0 and year 1. That was in early 2020. And we were aiming from the University of Lincoln perspective to deliver this early years and BMed-Sci component of the curriculum. I suppose one of the things about not having spoken to you for 2.5 years is that I'm able to now say that we've done this at least once around very successfully now. So we have students who have undertaken all of this teaching very successfully, I might say. This is teaching that is delivered by the University of Lincoln and quality assured by the University of Nottingham and subsequently by the General Medical Council. You'll notice here that we have a group of students who come in to year 0, a foundation year. That is a population of applicants who would meet certain widening participation criteria. And so we're diversifying the intake to medical education or undergraduate medical training quite substantially by that. And we also have a fair proportion of widening participation students who can make their way in via the normal entry route. So year 0 to year 3A, the first part of year 3, is looked after by the University of Lincoln. The students then pass on to the clinical phases, and this leads to the awarding of the degree of Bachelor of Medicine and Bachelor of Surgery. And this is under the auspices and completely delivered by staff linked to the University of Nottingham. And again, it's quality assured and quality managed by Nottingham. And just to give you an idea of where our current first cohort of students are, they've just entered year 4, so they're coming towards the end of their foundation for practice placement or clinical phase, with a range of different placements which you can see listed there. And so there are 75 medical students in year 4, which is a substantial increase in the number of medical students who are working across general practice, the Acute Trust, ULHT, and the Mental Health Trust, LPFT, within Lincolnshire itself. So we're making good progress, and we are anticipating that our first cohort of students will graduate in July 2024. That said, that first cohort have already graduated with their Bachelor of Medical Sciences degree from the University of Nottingham in the summer there. And we were hoping to have a celebration of their achievement in the cathedral, but unfortunately that coincided with the recent mourning period for the death of Her late Majesty. So we were unable to go ahead with that, but we would like to, we've postponed that and we're likely to go ahead with it in January. So we very much want to celebrate our students' successes and make them feel as if they really belong to Lincoln Medical School. In terms of student numbers, I think it's worthwhile just giving an idea as to where we are now. So when I spoke to you in early 2020, we would have been talking of there being around sort of 90 to 95 students in the cohort. You can see there the number of students that we had enrolled at certain stages in this whole process. This year in July 2022, our first cohort of 75 students graduated with their BMed-Sci degree, and we anticipate that all of them, hopefully, will graduate as doctors in July 2024. But we're not quite yet at steady state. So currently we have 370 students enrolled across the 5 years of the programme, and 19 of those are in the foundation year. And by the time we get to September 2023, we'll be at our full complement with somewhere around 450 students enrolled on the programmes, and we'll have 15 of those in the foundation year, gradually moving on to the main programme itself. So, as I say, I hope that from July 2024, colleagues at the in the NHS, and members of the public in Lincolnshire will start to see the first group of junior doctors who have graduated from Lincoln Medical School actually working as doctors, albeit as foundation year trainees in and around Lincoln and Lincolnshire. So I want to come back just before I finish to the aims of Lincoln Medical School. This is very much, as I said, about creating a medical school within Lincolnshire for Lincolnshire. We are aiming to be an independent medical school and taking in our first cohort of independent Lincoln Medical School students in September 2026. That's about a year and a bit. Just over 2 years, from when the first cohort of students will graduate. Now, this is a process which already has agreement from both the University of Lincoln and the University of Nottingham. It's part of our legal and partnership agreement that was written and agreed to in 2017 and 2018. So there's nothing new here, except that we feel as if we've made such success of things that we would like to become independent as early as we possibly can. This is subject to multiple approvals from the General Medical Council, from Health Education England and from the Office for Students, but we've already had tacit agreement from them to explore what we would need to do in order to become independent by this stage. And we have a meeting next week as part of a quality visit by the General Medical Council, at which we will be talking about our plans for independence and what that might mean for both the students but also the population within Lincolnshire. And so I'm going to end there and invite any questions. And I'm assuming it's okay to stop sharing my screen.
Okay, thank you very much, and thank you for the presentation. Councillor Allen.
Thank you, Chairman. If we go back to the start of your, thank you very much for the presentation. It was very good, and it's excellent news that the medical school, the Lincoln Medical School, is doing so well and is building on all the resources it needs to actually deliver some doctors for Lincolnshire in 2024, which is excellent. The question I've got is, it starts really with the point that was made right at the beginning in the paper about the need for more doctors, and the decision that was made to increase to provide 1,500 new doctors to go with the 6,000 that exist, to provide 7,500, and a decision made in 2016. I do wonder personally whether that actually provides a genuine increase in number of doctors, bearing in mind that so many doctors seem to be leaving or moving on to part-time work or whatever. Although obviously 1,500 doctors is better than not having the 1,500 doctors, so there is something there. I just wondered whether there's any likelihood of the new medical schools increasing outputs so that there's more new doctors genuinely arriving into the system, and so that we don't place so much demand on importing doctors to a great extent, which I think is virtually moving on to the moral in terms of taking doctors from poor countries to supplement our own numbers, and we ought to be doing it the other way around almost. So that was one question. Is it possible to increase the output of numbers at the medical schools like Lincoln or elsewhere for that matter? And a more specific question. What is the dropout rate within the medical school in terms of the 80 that are coming in each year, or will be coming in each year, when you reach the steady state situation? Are all our new intake such good quality that they sail through the training and automatically almost become good doctors in the future?
Okay, thank you very much. So in terms of the first question about the number of doctors that we can train, the number of medical school places in the UK is controlled by government. And that's because it's an extraordinarily expensive business to train medical students. However, I think everyone acknowledges, either tacitly or openly, that we need to be training more doctors than we currently do. And that's particularly important. It's particularly important, I think, to do that quickly because, as you've seen, it takes a minimum of sort of 4, 5 or 6 years to produce a doctor who's just at the beginning of their postgraduate training. So the numbers are controlled by government. There needs to be both political and financial will to fund those places. I know that certainly the Commons Health Select Committee have indicated that there should be an increase, not just to medical schools, but also to other disciplines within healthcare. And the Royal College of Physicians have stated that they think there should be a doubling of medical school places in the UK from about 7,500 to 8,000 to sort of 16,000, and that wouldn't produce more doctors overnight, but certainly would produce more doctors within 4, 5, or 6 years. And the opposition have said, as part of a sort of manifesto promise for the next election, that they would actually increase the number of doctors by, number of medical students by that number. As far as the new medical schools are concerned, I think many of us were set up initially with relatively small numbers. There was a degree of risk in putting medical students into new medical schools, but not as big a risk as perhaps people had anticipated. And so I can tell you that from our perspective, our building that you can see behind me has been built with space to take 120 students in a lecture theatre, as opposed to only 80. So we would certainly have scope to increase our training places for medical school students, but it really requires both political and financial will on the part of the government to release funding for those places. In terms of dropout, you can see that the number of students from the original 80 that we had in year 1, we now have 75 students in year 4. We have a couple of students who, through extenuating circumstances, have had to repeat certain elements of their assessment, but only a couple. And we had 1 or 2 students who dropped out because they worked out initially that medical school was not for them. So we haven't actually had any students leave on the basis of academic failure as yet. And usually medical schools, the dropout rate in medical schools is much lower than it is in some other programmes. It would often be as low as, non-completion rates would often be as low as somewhere between 2 and 4%. And we're certainly looking at around that level of attrition. So we're very similar to other medical schools in that regard, and that's because we take in people who have, extremely high academic ability. But that said, it's not. I wouldn't say that most students sail through. If we weren't challenging them, if they weren't struggling a little bit at some points, then we wouldn't really be doing our jobs, and we wouldn't necessarily be creating the best doctors for the future. So yes, we'd like to increase our student numbers. It's dependent upon numbers, funding being released and a call going out from government, and our dropout rates or non-completion rates are actually very low.
That was excellent. Thank you, Chairman. Any other speakers at this point? Oh yeah, Councillor Chalmers.
It all looks very positive to me. What are you really proud of having achieved in this process so far?
So I'm very proud of getting our first cohort of students who's, they didn't even get through the first year of their studies before the pandemic hit and we had to move entirely to online learning. So I'm quite proud of the fact that, even if it had been plain sailing all the way, it would have been a challenge to deliver the early years and BMed Sci curriculum effectively, and we have done that. As I mentioned in my presentation, we're extremely proud of the achievements of our students, those in that first cohort particularly. And it's just a pity. I wouldn't say it's not a pity that they have to graduate at the University of Nottingham. Obviously, that's their university and that's where they graduate. It's just a pity that we were unable to celebrate their achievements in the way that we wanted to at the cathedral because of recent events. So I think getting the students through that early phase impacted by the pandemic is one of the things I'd be proud of. And if I could maybe just sneak a second one in. When we get feedback from the local community, very often it's feedback from doctors who are seeing the students on GP placements and hospital placements, and some of them who see the students working as healthcare assistants and things in the local trust and elsewhere. It's very often extremely positive. So it's nice to see that we are bringing in a group of young people, generally younger than I am anyway, young people who both can make a success of their medical studies whilst at the same time making an impact personally on patients and on the healthcare professionals that they are either placed with or that they're working with in other roles.
Thank you. Councillor White.
Sorry, it's red still. I don't know why. That's what it should be. Okay. Are there any other courses that you'd like to set up? I believe there's a shortage of radiologists, for example. And secondly, do students have any interaction with the public during their training years? I mean, I believe some schools want volunteers, etc., for various studies. I just wondered that. Thank you.
So from the point of view of other courses that we might wish to start, so your specific example of radiology, or radiography, I should say, is actually being taken up by the University School of Health and Social Care. They already run nursing, midwifery, paramedic science, etc. And they're just starting a sort of postgraduate thing in physiotherapy, but they're looking at the option of running a radiography qualification of some description, because there is a big shortage of radiographers. I guess from our perspective in the medical school, we're very much at the moment focused on delivering the undergraduate medicine programme and that pathway to independence. But that's inevitably going to result in us identifying other areas where we can perhaps start programmes in the future. One of the programmes which takes up a lot of the consideration of medical schools is physician associates. And whilst at the moment we don't have any plans to start a physician associate programme, once we are an independent medical school, it would be easier for us to do that and deliver that type of programme itself. And then from the point of view of students and their contact with the public, students go out on hospital and GP visits right from sort of the first 2 months of their medical degree. They don't wait until the clinical phases to have interactions with patients. Albeit they're doing that in a much more controlled way than they would be as more senior medical students. So they do get a reasonable amount of contact with the public. We also have students who go out on outreach to local schools for various things. One of those is doing basic life support training alongside volunteers from Lives, and that's something we've been doing for probably about the last sort of 6 months or so. So they do feel very much, I think they do feel very much part of the local community, and we encourage them to do things where they can help beyond their medical studies, and hopefully as things open up or have opened up, there'll be more opportunities for them to do that than there perhaps have been in the last couple of years.
Thank you.
Thank you. I don't think I've got any other speakers. I've just got one question, if I may, and that's with the news of the Mablethorpe campus for future living getting the go-ahead. Will the university have any involvement with this? And in turn, do you feel this is yet another positive step to growing our own?
Yes, so the university is one of the partners in the Campus for Future Living project at Mablethorpe. Colleagues from the College of Social Science here at the university, and specifically from the Lincoln International Institute for Rural Health, are involved in that campus. So that's both researchers and people teaching on postgraduate courses. I do think that is a positive move, and it will help in terms of growing our own. But more importantly, I think initiatives such as the Campus for Future Living and other things which are being done out in the community are the sorts of initiatives that we as an independent medical school might be able to take advantage of. I would like to see, as an independent medical school, us doing things which are tailored to our local population, our local place and local setting, which is something the university is very keen on and very proud of doing. So initiatives such as that in Mablethorpe and other things are things that we will always be prepared to look at and get involved with if we feel that our input would be beneficial to the members of the public who are benefiting hopefully from those initiatives.
Okay, thank you very much for your answer. As I've got no further speakers, I just wanted to obviously thank you for your attendance today. It's always good to have a positive health story, really. It's rare it comes in front of the committee, so we welcome the progress with the medical school and look forward to support that the students will get and what they will provide to the Lincolnshire NHS hopefully going forward. So thank you very much for your attendance today.
Thanks everyone for your questions. All the best. Thank you. Bye-bye.
In which case, we'll now move on to agenda item 9, the work programme. Simon.
Thank you. Thank you, Chairman. If I could ask the committee to look at page 79 of the papers. We have 4 items on the list for the next meeting on the 9th of November, including the Hawthorne medical practice, which was recently rated as inadequate by the Care Quality Commission. Just picking up what's the items referred to earlier this morning, we will be looking for an item on non-emergency patient transport as requested. There was a request for an item on the sort of wider system approach to emergency care, not having considered the ambulance service. We're also going to have an update as well from EMAS in around 6 months. And the other thing is, of course, the committee's decision to participate in the consultation on the proposals for Ashley House, which, as I read the report, would be taking place sometime early in 2023, so January or February, but I will check that. I have nothing further to add, but I'm happy to take questions. Thank you.
Thank you, Simon. Councillor Allen.
Thank you, Chairman. I can't see it, and I've looked through, and sometimes interpreting the items in terms of whether you cover particular things is quite challenging. I recall that we had something from the United Lincolnshire Health Trust about how they were going to effectively spend all the extra money that they'd been given, and what their possibly recovery strategy was going to be, but in particular how they were going to start putting forward measures to tackle the quite significant levels of waiting lists that we now have. And whenever I look at the waiting list, it just seems to keep on going up from 6.4 million or whatever it was at the end of the pandemic, or effectively at the end of the effective pandemic, and it's now virtually 7 million. It doesn't actually seem to be coming down. Now, that's understandable to a certain extent while the various trusts within the National Health Service started to get their act together in terms of what it was they were going to do to reduce the numbers. I was a little bit concerned when we had that paper because it only suggested that there's going to be a 3% increase in throughput, which seemed to me to not, take, decades to actually get through the waiting list. I just wondered whether, and I can't remember how we left it, whether they were going to come back to us with more information, or whether that was just a first stab at a recovery plan. I just wondered whether there's something that we can request to give us some sort of feel that the National Health Service is, actually looking at dealing with the issues that we've got in terms of the waiting list. Because I do worry whether it's actually got any plans to do that, and I do worry whether they actually have got the resources to do it, and whether that list is just going to increase and increase and increase, and the only way it goes down is as people die off because they're not being treated.
Thank you. I'll bring Simon in a second, but I do recall, obviously, we've covered cancer care. That was just one element, of course, across the whole item, but I'm sure we did have an update requested to come forward that was sort of more wide-ranging.
Apologies if that has slipped off the list. I will try and programme that in, perhaps for January, where it looks as though there's the earliest gap. Thank you. Together with cancer care as well.
Thank you. The other thing I would pick up upon as well, I mean, for anyone who watched the news last night, one of the things that was picked up upon there was the waiting times in A&E at the moment. And I think, although we had an update, I think probably about 6 months ago, it's probably time that they come back forward. And actually, I'm not certain that it shouldn't be at the same time as we look at handover delays and try and pull it all together so that we're looking at it in a full circle, basically. So that would be a suggestion to sort of tie in with it all, I think. Anybody else wanted to raise anything? Colin, sorry, I can't see you here, so
it's
come through.
Okay, and I'm really sorry to try to extend a very long meeting already. Healthwatch have just started a programme about strengthening dentistry provision within Lincolnshire, and I know we've talked about children's dentistry provision, particularly in our very vulnerable areas, but might we be able to have a look at dentistry across the board within Lincolnshire as an item at some stage?
Simon, I'll bring you in. We did just recently have one across the board for dentistry. It wasn't just children's, but it is on the list again to come forwards.
Yeah, it's well, we've got an item on dental services from the NHS England team listed for January, but we are in a transition because the commissioning will be transferring over to the Integrated Care Board. So there is on the December list an item on the future commissioning arrangements for dental services together with ophthalmology and pharmaceutical services.
Thank you.
Thank you. Anything further? No, so I take it we're happy with the work programme moving forwards. So all that leaves us to thank you all for your attendance and patience, and look forward to seeing you all at the next meeting. Thank you. That brings the meeting to a close.